Girish Kumar, President of CSOS, Coimbatore Society of Ophthalmic Surgeons. And on behalf of Coimbatore Society of Ophthalmic Surgeons, I welcome you all for this exciting webinar on PG education and beyond. So we have with us great teachers, great academicians, innovators, practitioners to speak on relevant topics on PG education, career opportunities, and practice management. So beyond basic post-graduation, the career path offers diverse specialized opportunities, including subspecialty fellowships, senior residency, academic positions, and international practice. So by the end of these 2 hours, we would have covered main areas like how to prepare for the PG practical exams, choosing the right subspecialty, and navigating the transition to beyond. That is whether that's fellowship, academia. It may be writing a high quality paper for publication, or producing a high quality award winning video, or excelling in private practice. I want this to be a very interactive session, and we will have a dedicated question and answer session. We at least 8 to 10 minutes after each talk to tackle your specific dilemmas. And there is a slight change in the order of presentation. Dr. Santosh is going to present first, followed by Dr. Prashant, and then we follow the same order. Dr. DC will talk third. So this is mainly due to their prior commitments. They have to attend one more webinar. So going forward, I request our CSOS Secretary, Dr. Prabhu Vijayanathan, who is a cornea, cataract, and a refractive surgeon from Shankara Eye Hospital, to introduce our moderators and panelists. Over to you, Dr. Prabhu. I'll share
Good.
my screen.
So, good evening, everyone. And I'm Dr. Prabhu Vijayaraghavan from Shankara Eye Hospital, Coimbatore. As told by Sir, we have a well-renowned team up of speakers, and we have a moderators with decades of experience in PG teaching and mentoring students and helping them to move up in their career. And as a new venture, we also tried out to have postgraduate and fellowship perspective panel, a young and vibrant team of young people who are more interacting with the postgraduates as a panel. So I welcome Dr. Krishna Prasad sir, who is going to moderate us today. He is the head of the Department of Pediatric and Glaucoma, M.M. Joshi Eye Hospital, Hubli, Karnataka. He is vice president of Karnataka Ophthalmic Society and as a passionate teacher and a mentor for hundreds of students. And I also welcome Dr. Vanati Madam, who is a professor of ophthalmology and pioneer in corneal refractive ocular surface surgeries from All India Institute. And he is an editor-in-chief of IJO, who have authored more than 150 publications and multiple chapters in various other books. She is known for her excellence in surgical teaching of her postgraduates, fellows, and junior consultants. And she is known for her high-volume cornea transplant work. Coming to the panel, we have young and senior people who are very active and interactive with the postgraduates. We have Dr. Rajesh Prabhu, who is a senior consultant as well as the head of the Department of Pediatric Ophthalmology and Strabismus. He is also a DNB coordinator. He has more than 15 years of PG teaching and mentoring experience in Shankara and the places where he has worked before. And we have the all-known Dr. Prasanna Venkatesh Ramesh. He's the research director and glaucoma, head of the glaucoma in Mahatma Eye Hospital, Trichy. The next slide, sir. Yeah, head of the Department of Glaucoma in Mahatma Eye Hospital, Trichy. He has published more than 17 chapters and more than 55 articles. He is editor-in-chief for Tamil Nadu Journal of Ophthalmic Science and Research. He is part of the editorial board member for IJO, and he is currently joint secretary for the Young Ophthalmology Society of India and he backs multiple awards of national, state, and national as well as international conferences. And Dr. Rakshit Nathan is a vibrant young teacher in consultant cornea cataracts refractive services of Eye Foundation Coimbatore, and he is known for his awards, and he has backed 5 consecutive years of ERA quiz for himself. And we have the tech-savvy ophthalmologist, Dr. Pranesh Ravi. He's an excellent teacher, and he's running a deputy dean as a deputy dean of Muthuswami Virtual University, and he is known for his team leading work with the editor as editor for the Snippets podcast, and he has multiple academic contributions like 5 books and 15 indexed publications, 20 plus awards, and he is active teacher for most of the postgraduates. And I welcome you, all the panelists and moderators, to take over this session and bring good for our postgraduates and fellows. And over to Dr. Krishna Prasad sir for taking over this session.
So thank you so much, CSOS and all the people responsible for this webinar. I think the array of topics that we have is really exciting, and I hope a very vibrant discussion from the speakers as well as from the moderators and the panelists. So I think I think we'll start right away with the first talk. I think we can introduce the first speaker, maybe Dr. Santosh Honavar first.
Yeah, can I start off?
Welcome, Dr. Santosh. It's like it's very difficult to introduce him. He has so many accomplishments, and his area is vast. He was editor of AGO for 6 consecutive years, and he has received gold medals, many gold
That will be a
medals,
very
many
difficult
orations.
task. Very difficult
It's
to
very
task
difficult,
to
yeah.
explain, Dr.
And
Santosh.
yeah, it's a great opportunity for me to introduce him, and such a genius person, and his ability to relentlessly search for solutions and find innovative ways to improve the field is key to success. And his brainchild, that is iFocus, is the best PG teaching program and has been helping thousands of PG students to prepare and excel in their PG exams. Congratulations, sir, and it's over to you.
Thank you so much. Can I share my
Yes.
presentation?
Yeah.
It's very easy to explain him as the mass leader, whether the mass is in the orbit or in the eye, wherever he's there. And his sense of humor is beyond comparison. So that's Dr. Santosh for you.
Sense of humor I don't have, but sense of tumor I have. That's what you say, popularly.
Nice.
Trying to share 1 second. I have some technical issue. So I was asked to speak about opportunities for postgraduate students, and I choose to speak on fellowship mainly because in 10 minutes I can cover fellowships adequately. And I think fellowships are very important currently because residency programs have variable quality across the country, and fellowships are the one which actually prepare a postgraduate student for final practice. I think there is some problem in sharing. Yeah, are you able to see this?
Yeah.
Okay, great.
Yes. Yeah. Please.
All right. Okay. So, why, when, what, where, and how are the components that I'm going to address. Well, residency is like knowing ophthalmology comprehensively. That is true, but comprehensive ophthalmology is quite diffuse. It involves all the specialties, and if you are destined to practice in a third tier city or a small town or a large village, then doing comprehensive ophthalmology is perfect. But if your intention is to practice in a bigger city or want to excel in your profession in a particular area of interest, then diffuseness becomes a disease and you have to focus. Fellowships actually help you focus in onto a particular subspecialty, provides cutting edge knowledge because you learn the most advanced in your field at the time that you start your practice. It adds value to a ophthalmologist, opens up many doors which were otherwise shut, job opportunities tremendously improve after your fellowship, and obviously it helps find mentors. Fellowships are generally mentored very well in most of the institutes, and once you find a mentor, the mentor sticks on to you like glue for life. Of course, it helps you stand out from the crowd depending on what kind of fellowship that you venture to do and where exactly would you venture to do. Long-term fellowships are obviously most favored as compared to short-term fellowships. You have to do it immediately after residency, but of course you can do it later as well. Some have chosen to do it sometime in the middle of their career, but those generally tend to be short-term fellowships. Observership is just a dipstick test. If you want to do a fellowship under a particular mentor or in a specialty, you go observe them for a while and see if you fit into that place and if the fellowship fits into your larger scheme of things. So observership is not really recommended. It ranges from 1 to 4 weeks. It's only a dipstick before you start your long-term fellowship. Short-term fellowships are not recommended with the intention of practice, but if you already have learned several skills and if you want to hone a particular area of interest, then you can do short-term fellowship. It ranges from 3 to 6 months. Typically, does not provide hands-on training. What we are interested is to know about long-term clinical fellowship. It can be done post-DO, DNB, MD, MS, or FRCS. Typically 1 to 2 years, but some institutes have a 3-year fellowship. Highly competitive, provides excellent clinical and surgical exposure, and these are paid. We have long-term fellowships in all specialties, including comprehensive ophthalmology, and this is why we need it. Medicine attracts the brightest of the minds, and at the end of residency, sometimes you turn out to be something different, and that's mainly because of variations in the quality of residency training. And at the end of it, if you want to learn about ophthalmology in a proper perspective, then comprehensive ophthalmology fellowship is something that is useful. If you have done a DO, then comprehensive ophthalmology fellowship is very good. It will help you take the FRCS exam because DO is concluded as a subspecialty year and 4 years of training would qualify you to take an FRCS exam. If you have done an MS, then you can do comprehensive ophthalmology fellowship. Subspecialty fellowships depend mainly on passion, interest, and aptitude. And there are other several considerations as well when you decide on the place to do your fellowship. Reputation of the institute, the availability of academic opportunities, hands-on training, financial issues, and the intended focus area. There are many organizations which offer fellowship, and IGO typically provides a list of fellowship opportunities that are available. AIOS website and UOC also have these resources as to where are these fellowships available and what are the slots that are available. Subspecialty senior residency are also available, and MCH is also currently possible in cornea and anterior segment and retina. FNB is also an option for some of you who want to do a kind of a accredited way of subspecialty training. Now about international fellowships. Actually, international fellowships broaden the horizon beyond what you can learn in India, provides a much wider perspective beyond what is taught in India typically, and stimulates you to think differently and do differently. Now, international fellowships help you in many ways, and one of the ways international fellowships help is to learn beyond what you already learned in an Indian fellowship. So international fellowships are mainly, we think of short-term fellowships, which are 3 to 6 months, which may be sponsored by ICO and IOFF. Long-term clinical fellowships are typically 1 to 3 years, depending on the institute that you choose. Long-term research fellowships are available in basic sciences and clinical research. And there are collaborative fellowships which include an Indian fellowship. On top of it, you can get an international fellowship. Long-term clinical fellowships need USMLE except in California and Pennsylvania where USMLE is exempted. Non-USMLE international fellowships are available in these two states. It is best done after an Indian fellowship. So basically you need a J1 visa with kind of a mandate that you come back to the country of origin after your fellowship. If you want to settle down there, obviously you have to fulfill the criteria of coming back to the country of origin and at least staying there for two more years. Long-term clinical fellowship application would involve a good CV and a recommendation letter by a mentor. It is highly competitive, but it is not too difficult to get in. All the specialty fellowships are available. Now, how do you get to know about these fellowships? The best source would be SF Match. SF Match is mainly for those who are certified USMLE, but even beyond that, there are several fellowship matches that are available. SR Match timeline generally begins a year before your international fellowship timeline. Now, when you go into SF Match and search, you can see that if you search, you will get all these matches. And you can see it here that post-match vacancy is available. So this was a few months before which I searched, and you can search even now. You can see even in a university which is as famous as University of San Diego and pediatric ophthalmology, beyond the match, there is a fellowship vacancy available, which means that all the match candidates which are USMLE are filled up, and beyond that, there are vacancies available. Even for LSU Retina Fellowship, post-match is available, which are typically filled with good quality non-USMLE certified candidates, especially in Pennsylvania and California, where USMLE is not required. Even otherwise, some of these centers may offer these positions to non-USMLE candidates with special provisions. So it's a good idea for Indian uh, candidates to seek international fellowship spots post-match, which is easier than going through the match. You can see again that a surgical retina fellowship is available post-match in a particular private group. Mass Eye and Research uveitis fellowship is available post-match. Washington University Pediatric Ophthalmology Fellowship is available post-match. So these are low-hanging fruits which are very easy to get. Now, UCLA also has international fellowship in many subspecialties which are approved, and long-term research fellowships are plenty. It's very easy to get into United States long-term research fellowships. Many of them are paid research fellowships. These are some of the opportunities that are available for long-term fellowships. Adaptive optic imaging research, cornea research, glaucoma, ophthalmic innovation program. These are acclaimed. Harvard also has a Harvard Ophthalmology Research Fellowship Program, which is called International and Research Training Program, IRTP, and it's a 20 to 24-month program. RO website lists all the research fellowship positions that are available, some of which are named and are called award fellowships as well. You can see this comprehensive list of research fellowships that are available on the RO website. In Canada, fellowships are easy to get relatively. They don't need an exam except IELTS score of more than 7 is important. And if you go to the University of Toronto website, you can see the listing of these fellowships. And University of British Columbia also offers several fellowships. Canadian Ophthalmological Society also provides a list of Canadian fellowships. This is an Excel sheet that shows the duration of fellowships and the spots available. Canadian fellowships are hands-on and also are paid fellowships. International fellowships in UK are possible. You can go through these opportunities, the list that is available on the website that is shown. And this also lists the spots. UK fellowships are typically for 6 months to a year. And again, are paid fellowships, but you need registration with the General Medical Council, which can be obtained through PLAB or by dual sponsorship. These are the typical timelines for GMC sponsorship. It takes about a year and a half to get into UK because the process is quite lengthy, but it is very rewarding because even in MOVE fields, you can get fellowship opportunities if you apply on time and if you get the proper recommendation. About Australia and New Zealand, it's very attractive. Again, in Australia and New Zealand, you need only IELTS score of 7. You don't need any specific exam. These are also paid fellowships, and spots are available. Many Indians I know have got Australian and New Zealand fellowships recently, and they're doing pretty well. They're very happy with the surgical exposure and the level of training and the quality of training that is available in Australia. SNEC offers a number of fellowships for international graduates. These also don't need an exam, but the visa process is quite long, so we advise that they apply at least a year and a half in advance. ICO used to offer quite substantial amount of grant. They still offer, but what has taken over is IOFF. Offers several positions for 3 month and 1 year fellowships, which are paid like six for a 3 month fellowship. They pay up to about $6,000, which is substantial money for you to spend 3 months. And for a 1 year fellowship, they pay up to 20 to $30,000. And these some of these fellowship positions are listed on the website, and you can get into that. Community ophthalmology fellowships can be attractive for somebody who wants to practice it. The very good community ophthalmology fellowships that are available. Obis was attractive, no longer so. So basically, you have plenty of opportunities for doing Indian and international fellowships, and these opportunities can easily be kind of looked at if you're interested in further training in a particular subspecialty or otherwise. Thank you so much.
Thank you, sir. I think that was quite a comprehensive, compilation of what are the opportunities our PGs can have. Just a small thought, and I want you to respond to that. The elephant in the room is a good number of, our postgraduate centers in our country have a suboptimal, basic training. The
Mm.
comprehensive ophthalmology training is really quite unsatisfactory in many. And with that, our students get onto a fellowship and they become a particular subspecialist or a super specialist without the good foundation of a comprehensive ophthalmology. So that's why we have seen that trend, like every basic thing in either cornea or squint or even uvea, there is always a referral pattern. If you become a VR surgeon, even a basic corneal pathology, you will normally try to look for a corneal person to look for it. So is this a good development, and how we are going to solve this problem? At the same time, some of the specialties like VR, what we are finding is the poor surgical training or poor clinical training, they would be actually using up the time during the VR fellowship in trying to catch up with what they lost in the PG.
Mm.
They are like IUGR babies trying to catch up later. So a lot of good time during their actual fellowship is wasted trying to catch up what they did not learn in their PG. So what are your comments on this? And I want other panels also to probably discuss.
I think a stronger residency program is mandatory. So if you haven't really learned much during residency, especially clinical skills, theory, of course, everybody would have learned. Then many fellowships in institutes, especially I'm sure other institutes also offer same, but LVPI offers a initial basic clinical exposure across the specialties. So that particular 6 months or a year of exposure across all the ophthalmology subspecialties prepares you for a specialist training. So they don't lack skills if they start training intensively in retina, which means that they would have already trained in all the basic skills in other specialties. Then they go into retina training. So they get a broader base on which they build into their subspecialty skills. So which is available in some institutes, but they tend to have a longer fellowship duration. LVP has 3 year fellowship duration, out of which the first year is spent in general ophthalmology and secondary centers. Second year, they come back to do subspecialty fellowship and go on, so on. So that is one way of looking at it, but I don't know whether there is any crutch or a shortcut to a poor residency training. So unless we improve residency across the board, there is no way we can provide that kind of a crutch, and we will end up having a very narrow outlook in subspecialists who won't have a broader base in terms of other specialties, and they tend to kind of practice their own specialties, which is okay as long as they have the kind of outlook to refer at least when a patient needs a referral. Instead of ignoring the pathology, they at least refer to somebody who's capable of handling it.
You're muted, KP.
Any other? So when Dr. Santosh speaks, I'm speechless. So any other comments?
I think KP, I would be covering that part of residency, the state of affairs with the READ study and all.
Okay, okay.
I think
Then
we
I
can
think
also have further discussion beyond that, but that is
sure.
definitely a food for thought
Yeah.
for the parents.
I think that we'll keep this discussion for future. I think Dr. Shrish, can we go to the next speaker? Uh, that- Thank you so much, Dr. Santosh. That was an excellent coverage.
Thank you.
You're muted, Shrish.
Sorry for that glitch. So we'll move on to the next topic. Dr. Prashant Bondle is a dynamic uh, person from Nagpur. He's the present ARC chairman, and he is actually the past treasurer of Glaucoma Trauma Society of India and past treasurer of Veterinary Society of India and past president of Maharashtra Ophthalmic Society. And he has so many orations on his credit to his credit, and has won so many best video awards and best paper awards. So we'll move on to his topic, that is ARC for postgraduates.
Thank you.
Screen is yours, sir.
Yeah, you can unshare the screen, Dr. Shirish.
Yeah.
Then I can share. Yeah, my screen is visible now.
Yes, yes.
Yeah.
Yeah.
Okay, great. So thank you, CSOS, for this initiative. And in fact, I should commend the office bearers of CSOS for thinking about the postgraduates, like AIOS also has started thinking about it. So friends and the postgraduates, just a short introduction of what we have as an ARC offering for the postgraduates as on date, and why was it necessary? Let us understand through this presentation. So we welcome you to the ophthalmology residency. Well, as we all know, eye is the most precious sense organ. Almost 78% of the NEET clearing postgraduates, their top three career choices is one amongst them is ophthalmology. And for 21% of the people who are clearing NEET PG, it is first choice for them. If you look at the distribution of postgraduate seats in our country currently, you look at it DNB primary, DNB post diploma. So if you look at it comparative, total we have almost 550 seats, institutes which are offering either DO, DNB of DNB or DO or university or MS with more than 550, and there are approximately 2,784 seats of post graduation in ophthalmology according to the last NEET PG syllabus. So these are the various courses. DOMS initially was university recognized. Luckily or fortunately, we should say, the university thought that they would not carry on with it, and they converted all DOMS seat to MS. But unfortunately, the DNB has now introduced 2 years DOMS, DNB, DOMS at certain places. Then we have MSMD, which are 3 years, and DNBs for 3 years. So if you look at it, duration of the residence in last 50 years has remained the same. But if you look at the ophthalmology, the technology, the technique, the knowledge has evolved almost by 50 folds. So let us understand what is the various goals of residency training program. The primary goal is to train a resident. He should be fit enough to practice. That means Practice to become confident to diagnose, treat, and manage common ailments encountered in clinical practice effectively and with minimal error, of course. They should acquire. So that was the primary goal. And at the same time, they should acquire proficiency in good clinical and diagnostic skills, and most importantly, the surgical skills. Besides that, the other goal of various residency program is to initiate research by helping them out with journal clubs, writing their dissertations or thesis, which is their first research activity as a postgraduate. And the newer goals, via what should be encompassed in today's education, is about professionalism, ethics, soft skills, leadership, social accountability, advocacy, system-based practices, wealth, health, life management. If you look at the postgraduate training programs in our country, these other goals, besides having a thesis, which is more of it, rather, I should say, must do rather than it being evolved into a paper, that is all that happens in the PG programs. There are no journal clubs in almost out of 550 institutes which are offering. There are no journal clubs, no case presentations in majority more than 300 institutes. And leave aside the other part, teaching ethics, professionalism, communication, leadership. Well, this was never ever taught in any of the postgraduate teaching programs. So what are the clinical and diagnostic skills? Well, you should know as an ophthalmologist doing a slit lamp, A scan, 78 diopter. And this is the from our READ study, which was done on behalf of ARC and which was published in Indian Journal of Ophthalmology in 2017 by Gokte et al. So you can look, these are the basic things which we should know. And if you look at the things, our postgraduates to some extent know slit lamp examination in almost 60% of the institute, A-scan 78 diopter examination, well, indirect ophthalmoscopy applanation, not necessarily very good. Diagnostic, they might be exposed to some extent with B scans and NDR lasers and nowadays with OCT. But FFA, retinal lasers, orthoptic, squint, neuro-ophthalmic evaluation, subspecialty clinical evaluation is absolutely poor, and this is what the table speaks about. And if you look at the comparison of resident perception of clinical skills taught to them, you will see that it is very disappointing for them. Now, this is about the OPD skills. If you look at the surgical exposures and their confidence in doing various procedures like ICC, ECC, SICS, phacoemulsification, most of the postgraduates, if you go through these tables, you will see that these are the surgical skills, which I have just summed up it for you. From government institutes, NGOs, and tertiary institutes like Shankar Netralaya, LVPs and all, if you look at it, the surgical skills vary vastly, as has been already spoken by the previous speakers. Surgeries performed assisted, you can look at the skewed ratio, and other surgeries like trap, oculoplasty, orbit, retina is hardly there is any exposure in majority of the places. Maximum exposure is up to some extent about SICS. On an average in our country, if you look at the postgraduates, less than 50 SICs is what the maximum exposure of average medical colleges is happening. As I said, research, only thesis part is taken, and that is only because it's a part of their duty or a curriculum, not as a real goal to create a paper out of it. And this is what happens. And therefore, they are unable to publish or present it at local or national participation. So, and as I spoke about other goals, well, never is it a part of our any curriculum, I should say. So with this all background, after the READ study 1, which was done, now we have initiated READ study 2. We are waiting for the results to out. It has not differed much. So what was the thing we thought as a All India Ophthalmological Society, we thought we have been doing a lot for our members. Why not for our postgraduates? So with that intention, we have started a PG teaching program, and we call it, the tagline is a PG program with difference. Basically, because here we do not necessarily have only didactic lectures. We have decided to concentrate on case presentations, journal clubs, OSCE presentations, and comprehensive some soft skill boot camps, even the thesis, how to write a thesis, and all those, even the research workshops. So these are a few of the initiatives which we are doing on every Thursday. So this, it can be in the form of short cases, journal clubs. Yeah, again, I said journal club has become a dying entity from majority of the colleges in our country. And so we initiated and it has a phenomenal response. If you look at the clinical cases. We have a viewership as high as 3,500 to 4,000 per episode. Journal club varies from 2 to 2,500. But postgraduates, remember, do attend these journal clubs, because this is the way how you have to look at an article, how important it is, how much should you be trusting that article, and all this is all thought in this particular thing. Also, we cover the OSCE type of a presentations, where we cover how to interpret your various charts, like having a CT scan, MRI, how to read a specular microscopy, perimetry, and all those things. And of course, few didactic lectures once in a month, that is done only on topics which are not comprehensively available for you in a textbook for you. This was one of the other important episode which we did last year for the postgraduate, that was comprehensive guide for thesis writing, and these were 4 sessions which were guided by the most biggest stalwart teachers of our country, and they guided you. And equally important about today in learning, when you pass out, it is the soft skill which wins the patient rather than the knowledge per se of yours. Of course, your knowledge, clinical skills, surgical skills is mandatory, but how you tackle a patient, how you speak to him softly is most important. And with that intention, we had a soft skill boot camp in 3 sessions, and which was well taken. Besides this, ARC Academic Research Committee also has a PG refresher course, which is a practical course which happen physically at various corners of our country, and usually they are associated with the topmost centers in that particular region, with the aim to initiate the students to visit that particular higher center, so that they aspire to do more than their residency. And these are few of the visuals from those areas. To promote research, as a academic research committee, we have a young researcher award. So people who have presented their theses, the best of the theses are asked to present their presentation in the AIOS meeting, and the top 3 researchers are given a hefty prizes. Similarly, if you are having an innovative mind, well, we have Think Under the Apple Tree, where if you have some research ideas, and now with the help of an hackathon, which we usually have in conjunction with Dr. LV Prasad Eye Institute, these ideas can be taken to fruition, and it becomes a practical reality for you. Well, is the postgraduate teaching deficient only because of a ill-trained student, or who are the responsible? To some extent, our own teaching faculty to some extent might be contributing to it, might be in the form of that they are not that motivated, or they do not have an opportunity, or they are not upgraded to that level. And with that intention to motivate our own teachers, this is a program which we conduct at every ARS, All India Ophthalmic Society meeting, a full day program to stimulate and help the teachers and to motivate them to do better for them. And these are the challenges of teacher which we have been doing. Also, we want the young brains to become leaders in various spheres of life. And for that, we have a leadership development program for people less than 45. So after you pass your post-graduation, you should look for apply through your state leadership. And this is how we can help you in augmenting or your leadership skills, which not only helps you in your society, in rising through the society, but in your day-to-day life as well. So this is in short what ARC is trying to do for the postgraduates. And this is all possible because of my all 5 fingers of my hand, that is Dr. Kasturi, Dr. Anagha, Dr. Tinku Srinivas, and Deepak, who help us out in formulating big ideas for you postgraduates. So thank you once more. This is in short what ARC is doing for postgraduates, and more ideas are welcome what as a All India Ophthalmological Society we can do for you. Thank you.
Thank you, Dr. Prashant. Very impressive ARC, and for years after year, I think it's adding on more feathers to its cap. But the only I think the downside is, I think more and more postgraduates have to really come into this fold. I think at each medical college or the DNB institute, the teachers or their mentors should actually bring in the awareness about what AOS has to offer for postgraduates. I think the membership should be made compulsory. I think once the PG course starts, because even the fee to, I mean, the entire their membership fee is also very less for postgraduates. I think we need a very strong mechanism to bring in more postgraduates into AOS fold, that they can become the beneficiaries of all the programs that you are doing. So kudos to ARC, Dr. Prashant, you have done a great job, and best of luck. And I think we are seeing the best days for our postgraduates, with all the AOs firing all guns, all cylinders for our postgraduates.
Thank you. Thank you, KP.
Dr. Prashant, I have one question.
Yeah.
Like ERC, you are doing it is an academic and research committee, so it's more on academics and research oriented. But practically, these PGs are doing, like, many of the institutes are not giving them hands-on training for even cataract surgeries. Many of the postgraduates, they come out even without doing 10 cases of cataract surgery. And so once they finish their course, they go for cataract training first, and then go for subspecialty training. So they'll be wasting so many years. These 3 years of PG, they can at least learn the basics of cataract surgery. At least they can do good number of cataract surgeries. Any like think as a ARC, can you do something on this? At least they can directly enter into the subspecialty fellowship after their MS or DNB.
Dr. Shrish, it's a very valid thought, and every one of us in AIOS, rather across the country, who are into the think tank, are really worried about the quality of education which the postgraduates in our country are getting at the level of residency. So, as an AIOS for surgical hand skills, we have started at headquarters the AIOS Prayogshala, where they can have hands-on, not only on the live, but not on live patients, but some goat size and all those things. And what the next step of AIOS Prayogshala is going to be, we are trying to create sub-centers across the country, so that in South Zone we can have 1 or 2 centers where we are going to have Prayogshalas, where at least they can get some hands-on on the some growth size, and they become more confident with themselves. The second thought which you spoke about is what we can create a curriculum, and can we enforce a curriculum on various institutes which are running postgraduate courses. Well, the AIS is not having a constitutional power or a legal power to rather enforce any of this. We can only recommend, but unfortunately it goes on a deaf ears because we do not have any legal teeth. So that is the only challenge. And in fact, under Dr. Grover, we had created a syllabus for various subspecialties, and it was recommended. But the way the governmental system works, so unless the government really feels that there is a harm which is happening to the postgraduate, and it enforces that n number of surgeries of this particular category should be given mandatory during their residency, I don't see a good
Not
future
happening.
for
Yeah.
our postgraduates, unfortunately.
Sir, can I add a point from a YO perspective, sir?
Yeah.
Okay.
Yeah, sir, personally, the ARC Think Under the Apple Tree programs, which I started participating from 2020, 2021 onwards, it really had a impact from a young ophthalmologist perspective, because initially we were trying to pitch an idea that we were having. And from then onwards, it created a culture for us where we were able to take it into from a prototype to a real world commercial product that is actually readily available. And for people like me who had more trust and interest, even it helped us in patenting the bionest that you started, sir. Like we went the long way ahead. We were able to connect with like-minded people. I think like Suven sir, who was doing patenting for the BX ring, and then not only we did stop there, we were able to do a startup as well, sir. So personally, me, it's been almost 5 years since I have started my own startup as well, because we take these ideas when we collaborate with like-minded people, especially Apple Tree in ARC is very close to my heart, and that is one I really wanted to share here, sir.
Yeah,
Yeah.
Prasanna, I'm very happy to share with you. See,
Mhm.
think under the apple tree. Previously, we used to take it up to ideas. We used to give an award, say, of some amount
Yes, sir.
money and all, and that would end up. Since our last 3 years, we have collaborated with the Bionest from LV Pre
Yes.
Institute, and 3 ideas have become a market reality, And this AIOC, you will be seeing those three people whose idea is now a market reality, which we will be sharing with you in a short time. The time is not ripe enough to tell you, but disclose the
understand.
three products. But we will be having a technology pavilion and all what is planned at AIOC Jaipur, where our own innovators who presented in Think Under the Apple Tree, then they were groomed at Bionest LVP, and their idea is now a market reality, which they are going to showcase at Jaipur in a technology pavilion. Thank you for those kind words.
Okay, sir. Thank you. Thank you, sir.
Yes, Dr. Shrish.
Move on to the next topic,
Yeah,
KP?
yeah.
Okay, fine. Next, we have Dr. D. Chandrasekhar, one of my good friend, is one of the best teachers, PG teachers, and one of the best NABH coordinator, and he is coordinating almost 15, 16 hospitals of Aravind eye care system. And presently is the Honorary General Secretary of Tamil Nadu Ophthalmic Association, and the founder and past president of Coimbatore Society of Ophthalmic Surgeons. And he has received many medals, orations, has received Dr. Kumar Swamy Gold Medal for best performance in MGR University, and KG Hospital Award, received Star of KG Hospital from Dr. APJ Kalam, and he's received TNOA, Dr. J. Agarwal Award of Excellence in Teaching, and so many other awards. And so he can talk for hours together on NABH or infection control or HIC. So it's over to you, Dr. DC.
Thank you, Dr. Sirish. Can can you
Yeah.
stop share?
Yes. Yes, DC.
Just give me a second. Is my slide visible, Sirish?
Yes. Yes.
Yeah.
Yeah. Okay.
So this talk is going to be from the heart, and how to get through your practicals and Viva successfully. So greetings to you all from our wonderful city of Coimbatore, and Dr. Shirish and CSOS team. Thank you so much for inviting me. We have all big stalwarts, big passionate teachers here, and Dr. Santosh sir was outstanding. Prashant is an art and master of talking. Dr. Namrata madam, we don't have to say, they are all big and passionate teachers, including Dr. Chitra Ramamurthy. So thank you so much for inviting me. So this is tips for scoring high in practicals and Viva. What am I going to tell? The most important thing, who is going to be responsible? Is it the PG to get through? Is it the teacher? Or is it the institution? Sometimes we have seen people telling, I landed up in this institution, that's why I couldn't pass. Sometimes they say because of this teacher. See, actually, 50% of it is in the teacher and the institution, their contributions. But today, it is no longer only the teacher or institution. As Dr. Prashant sir showed, there are so many beautiful programs by our scientific committee, by our ARC, and our secretary at national level. We have programs at state level. So you are not at all short of good teachers and teaching. It is up to you to attend. What happens is, I've seen in webinar, initially it will be 180, 200, middle also it will be good. At the end, it will become 70, 30 like that. So you attend and listen to them. They're all golden pearls from golden teachers. First and foremost, here today we are in an era where institutions where they do not have much of exposure or specialties, they allow them to go for 2 to 3 months to bigger institutions for exposure. Today, it is all getting balanced because they know if they don't teach well or don't give them a good clinical exposure, then their seats will not get filled up, because today it is through the NEET. And once the NEET results are out, we get so many phone calls from so many of the prospective postgraduates finding out how are the classes, how are the stays, and how many surgeries we'll get to do. Everything they like to know before they choose a organization. So every organization is also stepping up and also giving them chances to go elsewhere and learn and come. But without the involvement of you as postgraduate, none of this will occur. One is passing the practical and viva theory. The other one is coming out successfully with flying colors. If you aim at coming out with flying colors, definitely you will never ever have problems when passing the exam. No, today DOs are very less. DNB DO is a very small amount of seats we have in the country, but we have to understand most of them are MS or MD or DNB. Their expectations of a consultant, of an examiner, is that you become a consultant mindset. This case, how are you going to manage? So, what are the investigations? You don't have to tell the minute things about surgeries and all. Principle of management. Trabeculectomy is the gold standard. I would like to do a trab, how it works. That's all. So transitional from theoretical knowledge to a clinical reflex, and spontaneous answering with the diagnosis, that is going to really give lot of inputs about your knowledge to the examiner. Sometimes they will end up giving you clues. So the management plan today, it is very important for you to tell how you are going. Not important only if you are going to make a diagnosis, but exactly what tests you would do, what you would not do, what drops you will put, and what will be the plan of management. That's all. So that is important for you to understand. See, overall, if you look at practical cases, there are about 60 to 70 cases I tell my postgraduates, starting from cornea to neuroophthalmology and orbit and so on, which can be kept in the exam, including pediatric like a squint, horizontal squint. These 70 cases first note down when you join your postgraduation. Please remember, there is nothing called theory separately and preparing for practical after theory. When you prepare your theory, what I have done and what I tell my PGs also, how many ever whoever is following, when you are going to talk about third nerve palsy today, or if you are presenting a simple case of even a hordeolum externum, prepare, go, because please understand ophthalmology is the most volatile. You will forget it in no time. You spend time. Today you write about lid swellings, all the hordeolum, externum, internum, chalazion, mainly at least. If you prepare in one page, now you will, you'll really be shocked to know there are so much things you will not know. 5 types of chalazions are there, so many pterygiums are there. Once you make your own notes, to go through a notebook, it will take half an hour, but to go through your notes, it will take only 5 minutes before the exam. So prepare for each of this, whatever subject you're preparing, write down. I know we can cut, copy, paste, put it in your word and forget about it. But if you write down and make a booklet, cornea separately, write in A4 sheets. Writing is as good as 3 to 4 times of just trying to learn by reading. So for all the 70 cases you have, write down and it should be with the practical in mind also, including plan of management from definition. Many people do not know definitions. What is a CSR? There is some immediate edema. No, apparently, spontaneous edema in the posterior pole, often occurring due to obscure etiology, can be recurrent, so on and so forth. Keratoconus, like that. So I used to tell my PGs and give them as assignment. Definitions is a separate set of things, because examiner, it will tell a lot of things. Definition will read. So you prepare. When you prepare for theory, prepare. Then your between the theory and your practical, you will get wonderful time to revise all these things. So practical, how you will take, will come to that. Ultimately, it should be comprehensive from definition, including your literal meaning, to the diagnosis and management and even differential diagnosis. The pattern of exams are different for MSMD and your DNB students. So, okay, we have a long case, 2 short cases, a refraction, and a couple of fundus cases for MS or MD, normally in this part of the country. And for DNB, it is OSCE. OSCE is a major chunk. and you have to score separately. One good thing about OSCE is if you don't know one or two, doesn't matter, you'll still pass. But in a long case, you flop, then it becomes a challenge to compromise with your short cases and refraction. Short cases, refraction may not be separate. All funders, everything will come within the short case. These are the patterns. Now, how are we going to examine a case? See, remember, examiners, as far as I know, real examiners will come and observe you, how you are seeing. Especially DNB people will be going to a third party center where it will be totally a new place except for a person who may be doing a translation for whatever they want, or for language purpose. Otherwise, they will see how you do your 90D, how you do your indirect. You must carry your one thing. Please carry your own indirect 90Ds, gonio lenses, and whatever, including direct ophthalmoscope for distant direct. Never, because in last DNB exam, there were 7 people who did not bring their IOs, and the examiner was quite unhappy about it. And including your, what you need for your smell, your taste, all those things you carry. And make sure you go with an open mind. Don't expect a clue. Of course, MSMD usually occur in own centers. Sometimes you get a wrong clue, you will end up presenting the wrong. So go with a fresh mind. See, history taking, you have 45 minutes for long cases in MS, whereas in your DNB, it may be only 15 to 20 minutes. So case writing should be perfect. Supposing you don't even tell, and if it is in the case sheet, they will accept it. But if you are presenting something and it is not in the case sheet, it will never ever help you. And color coding. Never ever forget to do color coding for cornea, retina, iris, angle. Everywhere you see color coding. That will tell volumes about your knowledge about how you're going to present. So this color coding, presentation, plan, everything should be perfect. So this is how sometimes you have DNB, 4 stations. One will be anterior segment, one will be posterior segment, one will be a lid adnexa, like that, and they will observe. So each session there will be one examiner. You get short time. You may not be able to write there. That is different. So long case you have to write, and most of the time, whatever you find, depending on whatever they're asking you to see, you make it and document it. That is very important. That is the best way to write, and you will never forget. Now this is something about OSCE. So OSCE, there are a lot of things. It could be just question. They can give you a time, 6 case scenario, and ask you to write what you are going to do, your checklist. I'm not going into the details of it. How you will do, even in your long case or a short case, your history taking should be precise. It is never ever going to change. Complaints, then you have your history of present illness. Always start off saying that apparently normal 6 months back. Then past, many of you have an idea, have the habit of telling past history, diabetic, hypertensive. Please remember, diabetes and hypertensive are not past history, it is a disease. So you can say personal medical history, known diabetic, hypertensive, coronary artery disease, asthma. It is not a disease of the past. So all these things you have to do. And you make a diagnosis. Supposing you're not sure, make a differential diagnosis and plan of management. If it is all in the case sheet, then you are safe. Your diagram should be perfect. Use your Amsler chart. You should know what you're doing. Many times they make a mistake of extending the vessel where they can't see also. You must know what are the 3 lines. So this is something for practical exams. So this is another OSCE. Here you have a finding. See, if you see for some time, on one side you have the disc edema, other side is a pallor. And you have something near the nose, and there is a into mark. So what findings? Ipsilateral, one side papilledema, one side optic atrophy, and anosmia. So what condition, cause for the condition, what condition will produce? So obviously, what finding you see, it is a ipsilateral papilledema, or one side papilledema, one side optic atrophy, and anosmia. So we are talking about a true Foster Kennedy syndrome, either a frontal lobe meningioma or olfactory groove meningioma. What is pseudo? You will talk about a AOA. Okay. AON can produce a pseudo. This is how you answer. Remember, even if you don't know one, you will get marks for the other two. There's a big advantage of taking an OSCE. You learn all this because when you take the foreign exams, it is going to help a lot. Now, this is one major neglected, whether it's a long case or refraction case, you must know how to do all these things. They may keep a dilated case only for retinoscopy, and you must know all the aspects of vision refraction. There is nothing to say. You see, we end up in the clinic, complete workup done by refractionist. See that, just sign the glass prescription. Tomorrow, when you sign the prescription, you are legally responsible for it. Even after you finish your exam, your knowledge, this is the basic foundation of your entire ophthalmology career. If you are strong, you will never ever give a wrong prescription. Learn retinoscopy. See that you should have fast, once you start doing, you can verify very fast and then go ahead with that. So these are some things which here you can see the paramedics do for us, and they are absolute, they are experts in it. But then you have to understand, you should know every bit of it, unless you sit and do many times. See, initially I would advise you to ask your institutions to get the modelize and practice. Don't practice on the patient for hours together and then make him very vexed. So try in the model eye, and then now today we have so many dry labs at all India level, at state level. You can use all those things. Now, Viva exam is all about spontaneity. How will you ever answer in your Viva exam is depending on how we are prepared for 3 years. Familiarity. I'm not going to go into detail. So it could be images, it could be instruments, it could be drops, it could be any kind of a trial set, or it could be a Placido disc. Everything can be part of your Viva. Community ophthalmology is also part of the Viva. They may also ask about your thesis and your logbook. So remember, you should be able to read an image, which eye, reliability factors, what are the 7 parameters, what is the glaucoma field, and of course, always when you read an image, you have to correlate with your clinical findings. So these are all things, you must be familiar and know how to present. It is like this. For example, this trial set can be there. They can give you a phaco and from supposing an instrument is asked, from there they can go to any question. So now this is the example where it can be a OSCE, it can be an OSCE also, or it can be, today they have digital images and ask you. So here, beautiful smokestack appearance, CSR, you should be able to define and tell everything about that. So when if fluorescent comes, you should know these basic aspects. See, unless you learn the basics and present just by smokestack, you cannot go. So what are the types of hypo, and so on. So when you're going to talk about fields, neurological or clock, unless you know all this, you are not going to present. You should know how to read, how to correlate, and tell what is the site of lesion. Field defects in neuro-ophthalmology is like mathematics. You cannot make a mistake. So similarly for glaucoma, everything is very important. How to read an OCT image. First, you should know how to read. There are our own Prashant sir is a beautiful expert of OCT image. How you are going to read? What are the, unless you have seen this repeatedly in your practice, you will not be, because what images they give in the exam may not be the same like what you have. But if you have sound knowledge, it will be very, very good. So this is a what you kissing pigeon sign or trap claw, you'll immediately say what is your diagnosis, isn't it? Pellucid marginal degeneration. Now, regarding instruments, I'm telling you, you should know all the sometimes you go to a center, there may be some old instruments or newer instruments. You should be first able to identify, number one. Number two, once you identify, you have to tell why you have identified like this. Why is it whatever curved surfaces, or whether it is a Vanas, whether it is Hoskins, whatever you have to tell. Now, once you identify, the questions will be what are the uses. Supposing you have an enucleation spoon or something, they'll ask you what are the indications, absolute indications, relative indications, some steps, where will you break in DCR. So the entire idea of instruments is to know your knowledge about one, whether you know the instrument, two, about what is its use, and two, about the things. Another important thing in the Viva is first you must know how to identify a slide. First, whether it's a microbiology slide or a pathology slide. Mostly you have this purple eosin color. So once you know it is a pathology slide, you should know whether it is black color, white color, whether it's retinoblastoma. Then you have a slide like this. You can have a samoma body. You can have rosettes. You can have fisherman net, dictyoma or malignant melanoma. All the four you are seeing here. Then once you see that, you must go and further and say whether it's a spindle A, a spindle B, or a mixed cell. All these things you should be only, see, these are only few slides they'll keep in the exam for pathology micro. Somebody is there who has taught you, you get all the things and go on revising. By looking for the first time, getting a clue, you will flop. It will be very difficult to answer the exam. So these are small things about practical and Viva I thought I could tell you. And definitely attend classes, listen to wherever. Today, all India and PG, we give lot of importance for programs for postgraduates in the state and national level conferences. So we have teachers of tomorrow and so many things, PG refresher. Make best use of wherever you're getting the resource, not only from your institution, and do well. Wishing all of you the very best. Thank you once again, CSOS and Dr. Shirish Kumar, for this wonderful opportunity.
Thank you, sir. I think you are the master teacher. I think every postgraduate probably will like to listen to this and understand how to get through the ordeal of examination. I think any student, however bright they are, however, what track records they have, exam is their D-Day. I think their personality types, so how, whatever the stage fright they have, it is completely going to upset the plans for the exam. I think guidelines from people, mentors like you will probably make the job uh, pretty simple and navigable. Sir, I have some questions from the student side. I think these are the four questions any student would like to ask you. On their behalf, I am going to ask you. Sir, in any MS or DNB, especially in DNB, the time given is too short. If there are 10 candidates and you are the one to really come, you may not hardly get 15 or 20 minutes per case. And the case can be anything. It can be a proptosis, it can be a ptosis, it can be a uveitis. So what will you do if the time is too short? Sometimes the center is some other place. We have language problems, there's transcription errors, and some patients are seem to be uncooperative, and the setup is new. So with all these shortcomings, if
True,
the
sir.
time is less, if the
Yes.
student is not able to examine completely or write completely in 20 minutes, and you are called, you say you finish, come first because you are the one in the line. So the last student gets 4 hours and the first student gets 20 minutes for the same case. So what is your advice to the student?
Okay, sir. It's a question, very important question for DNB candidates, sir. Number one, the same time is given for all the candidates. Even the last candidate will get 20 minutes and the case sheet will be taken off and given to the examiner and the first candidate. But usually in our centers, we have all 10 different sets of cases for 10 people. Mostly it is never repeated. Number two, some long cases they have to finish. There is no question of telling I'm not able to see. They can ask the invigilator for probably another 5 minutes, but finish and come to a diagnosis. The major problem would be to write the complete long case. Long case could go up to half an hour at least, sir, in that. But like proptosis and all, it is minor it may be a long case, but they have to make sure that they finish the case. They can get a few minutes extension. Usually, the skilled expert assistant or whoever it is will allow them. But there's no question of not finishing the case, no exam. But the time is usually what we do is same time frame for all of them. And the different cases are kept. So mostly they don't get the same case at all. This is what is
Okay.
my answer.
So, but the most important question, what if they can't come to a diagnosis in 20 minutes and you're called? You're presenting a case and you don't know the diagnosis.
So if it's a complicated case, as a FAT examiner or whatever, a good differential diagnosis will be accepted provided they justify, sir. For example, I will tell you there was a situation about 3 months back. Our PGs went to another state for an exam. All of them ended up getting only retinoscopy as long case because that particular center did not have long cases. Luckily for me, I was so happy there because I've been trained like how sir is an expert and passionate about refraction. They all did retinoscopy well, but sometimes some of the centers are not the same. Some of them do not have some kind. Some of them they do not give some accessories. But if you don't know the diagnosis, if your findings are correct, definitely the examiner, a reasonable examiner, will accept the findings and the differential diagnosis.
So the same thing in a Viva OC, like they ask a question and the student has never heard of that. Or there's a sudden mind block or a brain fog and he can't remember or she can't remember anything. Then what do we tell the examiner? We say we don't know, or you say we have forgotten, or what is the best way to respond? And as an examiner, how will you take it?
Sir, the mind block is a problem for some people who have never got exposed to presenting to their teachers. I keep telling them present, 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 and keep on answering. That mind block will never come. But there are some people who get really tensed up and get. But Sir, I have it in my mind. I'm not able to get. Just give me 2 minutes like that. You need to, but most of the examiners get and not get. But there are very reasonable examiners who will give a clue. They will give a clue, but it all depends on your luck also, sir.
And what if you answer wrong? Is it okay? Or, I mean, like what is the basically, I mean, how do an examiner
Sir,
decide to pass or fail a
sir,
candidate?
if you
What is
are
the
me or
criteria?
you, if they are in the right track and somewhere minimal they are going away, it will be acceptable. If they are totally off track, for a non-connected condition or imaging, then God is great only, sir. They have to pray to God.
I think a
I
very,
have few
very good
points
answer.
to say, sir.
Yes, Prabhu.
Usually, usually they fail themselves. That's what I always think. Uh, the examiners usually wanted to pull them off. And two things I wanted to add. One is like nowadays, what I felt as an examiner last time is like postgraduates are able to answer even the latest of the machines like ASOCT, Heidelberg, tomography, or Pentacam, Antirion, and other things. But when it comes for basic things like for an instrument, basic, I was surprised that none of the postgraduate recognized the test chamber of a phaco machine or a phaco sleeve or an IV cannula used for phaco. But I just asked them, are you doing phacos? How many phacos have you done? As a clue. But since I've done 10 cases of phaco, and but still they are not able to recognize the instruments of a phaco, a basic phaco machine instruments. So probably I feel that sometimes it is also like they are becoming too specialized into modern things and do not concentrate on very basic things also. And probably that is my could be my perspective. Also, I want clarification from the others. We have panelists like Dr. Rajesh and Prasanna and Pranesh and Rakshit. So what is your views on things
Before they
about?
answer, Prabhu, see,
Yeah.
I'll tell you something, no? The teaching is starting from basic only for the PGs. They must be taught that. Sometimes what happens, our super experts end up talking at their level more about highly complicated things, which that only the PG will remember and try to tell, and the rarer things. So that becomes a little bit of a problem for them, and they forget the basic things. That is also there in the basic teaching. Over to others. Thank you, Prabhu.
I would like to add
Dr.
two
Satish,
points with the Dr. KP says
can you
doubt.
can you allow me to talk soon because the network is very bad here where I'm now.
Can I add few points for Dr. KP says doubts?
Yeah, please.
Yeah. So now I think National Board has clearly given instructions for the examiners to conduct when they conduct the practical examination. No more long cases, short cases format. It is only two clinical cases. So that is why when the students come to us for exams, we clearly tell them that within the 20 minutes, try to examine the patient and mark down the key important points alone for presentation. We don't want them to write a long history right from chief complaints and then end up everything till the diagnosis. So we don't get the case sheets from them. The case sheets is only given to them only to note down the points and present. I think they are not supposed to submit the case sheets also to the examiners. So we tell them to first give 10 to 15 minutes of noting down all the important positive findings from the examination point of view and a short history, and then 5 more minutes for them to write down the important points in the case sheets to present. So that's how I think it goes in the examination. And Viva, again, they have given clear instructions to examine each candidate for 10 to 12 minutes. So as said, sometimes there might be a thought block, sometimes they might not know the answer for the question. It is better for them to tell them that I don't know the answer so that it gives an opportunity for the examiners to ask more questions in the 10 to 12 minutes time. So probably the number of questions they answer, it is easy for us to grade them. Rather than beating around the bush, even if you don't know the answer, they try to drag and they try to like do something about that question. No, it's better to tell them that I don't know the answer so that it gives the examiners an opportunity to ask more questions in that specific 10 minutes time.
True, Prabhu. True. Actually, in
Problem.
Viva also, no, it is quite, you're not going to fail because of one or two poor Viva
Exactly,
answers.
exactly, exactly.
The instructions for DNB are very clear. As you said, two cases, only positive findings to write. That's all. So it is easier, but still challenging for very long cases.
And how many of the examiners follow this? I don't know. The DNB board very clearly say that to ask the same set of questions for the all 10 to 12 candidates. So we need to frame 4 or 5 questions about the topic and then ask the same set of questions. So I don't know,
In
sometimes
Viva.
Viva,
Correct,
yeah.
Thank you,
Sir,
Rajesh.
sir, and in our PG institute, sir, our HOD emphasized very clearly on retinoscopy. So though at that time it seemed a bit resistive and I was not a very great student back then, but the skills that he told us, Srikanth sir was my HOD, that you need to practice retinoscopy again and again. And 5 years later, sir, when we are going in for competitive exams like FRCO or other exams, so each station gives us only 5 minutes. So if you're aspirant in going for these exams, fellowships, settling abroad, and these kind of exams that Santosh Anavar sir was talking about, so you have 10 stations, each 5 minutes, and retinoscopy was one of the ones. And Pranesh and myself, we wrote FRCO refraction exams together. So within 5 minutes, you'll have to finish your retinoscopy, and there is no other option. You should have done a certain amount of retinoscopy with certain experience. Otherwise, you will not be able to move through those stations. And as DC sir was pointing, sir, I wrote my DNB exams 3.5 later after my MS. So I was more into academics a bit late after my fellowships and other things.
Both
So
wrote
I
together.
went back. Yeah, both of us wrote together
Okay.
again, like FRCO.
In Coimbatore
So-
only we gave the exam.
Yeah, Coimbatore Arvind we gave. So we again went back to me and him registered for IPEP program just because Dr. VRV sir was taking a 6-hour class of all A to Z basics. As DC sir was telling, the basics that you get from teachers are totally different from what we get in conferences because that is completely an exam driven one. So I think I speak for behalf of Pranesh as well, where we wrote FRCO and DNB together. Retinoscopy and all these basic stuff still holds good, sir. And we all realized it. I mean, I'm grateful to my teachers, but luckily we did it, so we were able to reciprocate it in the exams as well.
I can
Dr.
just
DC, I have one question. DC,
Shirish, yeah.
this is regarding retinoscopy. You still insist on PGs doing retinoscopy and giving more importance to retinoscopy
You
because,
don't want them to
I
pass.
think
You don't
it
want
is
them to
right.
pass. You don't
No,
want them to pass.
I know, it is important
Retinoscopy
to
is
pass the
a
exams, but
foundation.
how practical it is,
It
I
is.
don't
It
think
is
anybody is
foundation.
practicing retinoscopy after
No,
their
I will
maybe
100%
in
deny
very
that.
remote
I'm
areas they
sure
do it.
we have
So,
all other teachers.
lot of people who are doing retinoscopy in their private practice. We are all in a bigger setup, so it is very important that retinoscopy has to be mastered, and people should know. Only then they can question the optometrists also about what they
Absolutely,
do.
madam.
So
Absolutely.
it's
In a
totally
tertiary care
not to
center,
laugh at all.
every glass prescription is given after verification only by doctor.
Yes.
Yes, I think it's getting late, Shirish.
Yeah.
Thank you so much for the opportunity.
Thank you. Actually, Dr. Chitra is traveling in some part of remote villages of Kerala, and she wants to finish her talk. Is it okay,
I'll
Dr.
be after
Prasanna?
Chitra, no?
Yeah.
Yes,
Or
ma'am.
I'll be after Chitra, or I'll be after you let
Okay, I
please
think
can you let me
Prasanna
know
can
the
wait.
time?
Ma'am, I'll go last, ma'am. No problem.
Yeah,
Prasanna will be
okay.
the
I think then we'll have
finisher.
Or you
Dr.
do one
Chitra's
thing
topic.
to finish. Okay.
Okay. Can you all see my presentation?
Okay, yeah.
Can you see the
Mine was
presentation?
actually third.
Oh,
Yeah,
no, I'm
it's
I
sorry.
was third actually.
Yeah.
Ma'am, I can go
I
last, ma'am.
reached Kumargaon and I'm sitting in one dark area just because there's network and I'm talking. So sorry, I'm very, very sorry to have bulldozed like this. I'll try my best to complete my talk as soon as possible. My due is to talk on evolving and growing in an ophthalmological practice. Now, interestingly, there are two pillars when you're talking about going into a medical practice. One is the science of ophthalmology, and the other is the commerce. And the funny part is, he has spent 10 plus years of training in the medical science of it, and there's absolutely no formal training in the business of practice. And I think this is something so relevant when you're just finished with so much of confidence and absolute ego that you're right on top as far as the science and technology is concerned. But when you get down to the grassroots, you realize that you wish there was some particular training you had had about this. And the very big questions which come in is, where do I fit in? Do I fit into a solo practice? Do I fit into an institution-based practice? Should it be a group practice I should look at? Or do I go and join a corporate model? So essentially, what is this art of business, which I seem to talk of as if it's as relevant as the medical science? At its core, it's transactional. In other words, if you are going to deliver your best in this business of ophthalmology, you are going to reap the best. So then the next role comes, and many of us being women in ophthalmology too, you have to define what is going to be a level of involvement. Now, there are different practice models. If you're looking at a private practice, a small scale private practice, wherein you think you would start off small and look at it as it goes on, as how it expands, and then take it up, then you could find that you are able to take a small amount of loan and start off in a smaller fashion. But if you're looking at a subspecialty practice where you've done your fellowship and you want that component of your training to also evolve and grow, then you need something a little more large scale, a little more infrastructure. There have to be more systems and processes. And more importantly, it cannot be a part-time involvement. It has to be a significant commitment. When you look at the basic staffing needs, which you're going to need when you're going to start your practice, you have to be very clear that it has to be a very smart purchase, even of your basic instruments and operating microscope, anything which should last a decade. But it need not be the best of it, but something which will give you end results which are quite good for your patient, a clear cornea and a fast surgical time. But again, it should stand the test of time. It has to be a robust machine. You have to negotiate hard. You have to look at the long-term service contract, the CMC, AMC. You have to consult your colleagues and friends, even a senior for that matter. And you are stuck in a moment when you have to manage your resources very wisely. You may get small loans. You may have to have the ability to handle small loans, bank loans, which comes away. And then you start growing and you come to a point when you have 25 plus, 30 plus in your practice. Then what you would do is you would like to add an optical outlet, a pharmacy, better accounting systems. Now, what you have to do is you could lease your optical outlet to any of those other bigger outlet people who come forward, or you could choose one of your senior younger optometrists or any other management guy who's in there very committed to you, and you could ensure you help him along to establish an optical outlet and give him some incentives so that there is an added interest to get that extra income. If you want a small pharmacy, you need to have a licensed pharmacy person, trained person also, but he could be a part-time person and you could still run that place under his license. But now you have accounting more than what you are getting from your clinical patients alone. So two other outings. So you need to have better accounting systems. You have to start looking at implementing daily revenue reports, weekly, monthly analysis to know how you're progressing. Are you growing on a weekly basis, on a monthly basis? And you have to find out what are the weak links and you have to address that. Hello. And then it becomes even more important that you have to start adding marketing efforts to it. You have to have a basic digital presence which is relevant to your area of practice. You don't have to overspend on it, but there has to be a community outreach which has to be incorporated in that. You need to have connect with the local NGOs around. You have to have some rural camps. You could start with just one counselor or just one PRO, but you have to tie up with the local societal Lions Club, Rotary Club, whatever is available there. Go give your meetings, expand your team, and ensure gradually, day on, you have a robust staffing team. Initially, there would be people who will do multi-purpose. They would sit in the optical outlet, sit at the reception, come to you with the theater, where you initially have a smaller staff, but then you start increasing it. Then as your system grows, you have to now have a better reporting structure. You have to have review meetings. It has to be very, at least once a month initially, maybe more frequent with the smaller heads of departments of the different unit, like head of ward, the head of theater, and head of the refraction unit, like that. Split it into different segments and have a head for each of it. You have to start having performance appraisals so that incentivizes your team. They know they are going to get recognized, they're going to get a salary increase, so they perform better for that. And then now your marketing cannot be just restricted to that area or region. It has to become a little large scale so that you get people from the neighboring outlets, areas coming into you, because you have come to a point where you're going to offer something more. Now, when you have so many more things happening around you, you need to have a professional finance and an HR team. So what are the key roles which will add as you grow on? You should have a chartered accountant, an HR manager. You need insurance tie-ups because there are going to be at least 30-40% of your patients who are going to come in with cashless things. And so you need to have tie-ups and you need a coordinator. You can't just have an insurance tie-up. The money, the insurance has to be paying you back the money and all that has to be followed up. You can't be allowing your patients to get a cashless and your insurance money is not coming back. You should have a strong front desk. Definitely a very strong front desk, the smartest of the team, and a call center as time goes on, wherein they take your appointments, your cancellation appointments, your OT scheduling, calling up patients before the surgery, calling them after the surgery. And while all this is happening, you have to ensure that you're implementing MNABH protocols because your insurance tie-ups are going to demand that. So then you have staffing requirements, and now your HR has to step in, take the interviews, the appointment letters. You have to have training for them. Soft skill training has to be an ongoing process. There has to be initially on probation. You have to upgrade the skills. They stay with you for a period, a week, a year, or 2 years, or a decade. Their skill has to be upgraded because that only gives them the interest and the challenge which you are charged with, which you have to charge all of them. You have to look at the leave, the attendance, the salary structure, which has to be coming out payment on a regular basis every month. And you have to even address the resignations in the most gentle manner. There cannot be a fight across the table. It has to be addressed properly. You try to retain them, but if you have to lose them, you lose them in such a manner that they do not spread a bad word about you. As you still grow, you'll find that you can't just have one head, clinical head. You need to have a medical person heading it. You need to have an administrative head who would look at the overall responsibilities on a day-to-day functioning. As you grow on, you look at the comparative practices in and around. You have to adopt newer technologies. You might have to be the first to, so that first in that region, that gives you an edge over the others. I'm not asking that you get competitive and alienate them. You have to grow along with them, but then you have to do something more to your setup. You have to have benchmarks for your finance, for your strategies. You have to compare and contrast the technical upgrades which you have. What is this particular IUL is doing to you? What is the advantage? So do an analysis, do studies, do everything which is possible. And each decade, there has to be a growth which you have to understand and appreciate and find out the weak links, then ensure with each year there is a new learning. While all this happening, you look around you, you realize that you have to have the financial literacy. Not just having a chartered accountant there is going to help you. You need to know what is EBITDA, what is profit before tax, what is MOA month on month, what is year on a year comparative reports. You have to have a good finance department. You have to have NABH standards, you have to have insurance tie-up, you have to have cashless processing, you have to get a systematic claim processing, a follow-up which is happening, a clear reporting when you talk to them. And then you also have to see whether you are running a financially viable model. You have to define your specialties. You have to look at your target market. Where are you going to spend your marketing? What is it which is going to help you go further? And while all this is happening, there are a lot of people who have added on your system, you also choose a correct legal advisor, ensure your financial structure is sturdy. When you're looking at your operating efficiency, you should not overbook appointments, nor are you going to underbook. You have to know how long your patient is going to be in your room and accordingly ensure that there's an even distribution of files coming in. You have to have an EMR software, a basic one initially and later upgrade it. You have to ensure your system has grown to a point wherein you have some kind of a fellowship program for your optometrist, your front desk people are trained, your patient coordinators are trained, your technicians are getting trained and retrained. You have to ensure that you're delegating it. You can't be having all of it on your head. You should have people under you in your verticals who doing it well. You have to strengthen all your verticals, your medical, your surgical, your optical, your pharma, your insurance network. You have to improve your collections. You have to come to a point where it's not just an EMR, but your ERP systems have to evolve, which will see that all these systems and guidelines and protocols, and only thing you have to feed the data and the whole processing, which is going to evolve. You have to enhance your online presence. You go to Google My Business, you improve your website, your Google reviews, the SMSs have to go, the email reminders have to go. You have to engage with the local community in every possible way. You have to negotiate your pricing of your intraocular lenses, your instruments with the vendors time and again. You decide whether you're going to bulk buy it or you're going to lease your equipments. You have to ensure that you come to a point where you can even consider teleophthalmology for follow-ups for the people who are coming in from the remote area. Constantly track the key parameter index, whether the patient volume is growing. Is it a 10% growth you have anticipating? Is that happening? Are your surgical numbers going up? Do you realize there are some who are not turning up? What is the reason for those no-shows? Are your optical sales improving? Can you go on to having a branded setup, branded glasses along with it? In all respect, you have to be ahead of the curve. You have to be your king, the kind of king you want to be, with compassion, with leadership, with doing the best for your society. You have to grow along with the corporate tie-ups. You may be going into investment networks. You want an academic presence. You maybe want for an office bearership in the different societies, the state and the national level. You should finally also have a retirement planning. So believe me, friends, this journey of evolving and growing in practice is a journey which is ongoing. You have to evolve with intention. You have to scale with wisdom. But remember, the competition is not with others. The competition is with yourself. And you have to continuously compete so that you are where you admire yourself to be at the end of the race. Thank you very much. And last but not the least, I cannot do anything, any of the best ideals and intentions I have to be the kind of vice president which you would want to be. So friends, please do keep this in mind. I'll give my best given the opportunity. Thank you very much.
Dr. Chitra, I thought you were a pro in ophthalmology, but you seem to be a business wizard also. I think this talk is not for young ophthalmologists, for everyone, all of us. I think we learned a lot from this. I think every organization, however big or small, can benefit from your thoughts. Very well compiled, excellent talk. And that too from some remote, poor connectivity area, you connected very well.
Thank you. Thank you so. Thank you. Sheesh, you have muted yourself. Unmute yourself.
Yes, I think any questions to Chitra from the panel?
I think we'll go to Dr.
So,
Namrata.
okay, yeah. Uh, I think we'll move on to the next topic.
Sorry, would you
Sorry.
mind if I disconnect, Shreesh? Thank you so much. I would never
Thank
do
you.
this otherwise. Thank you so much.
Thank you. Thank you. Thank you
Thank
very
you,
much.
Dr.
It was a
Krishna
nice
sir,
talk.
for your very kind words. Thank you.
Thank you. Thank you. Thank you. Thank you very much. Now we'll move on to the next topic by Dr. Namrata Sharma. Sorry, madam, for making you wait. So, very extremely sorry. And so we all know there is no introduction needed for Dr. Namrata Sharma. She is a true scientific and academic leader. And she's a true ophthalmic politician also, and she has held many important positions in various societies. And presently, she is the scientific committee chairman of All India Ophthalmological Society, and she was the president of Eye Bank Association of India. She was president of Caracon. She was president of DOS and so many other organizations. And presently, she is a professor of ophthalmology at All India Institute of Medical Sciences, RP Center, and one of the most powerful women ophthalmologists in the world. She has received more than 20 orations and more than 20 gold medals. So the list just goes on. She has more than 119 textbook chapters to her credit, and she has authored 23 textbooks and more than 800 publications in peer-reviewed journals. So many achievements. So it will take more than half an hour to complete her list of achievements. So we'll move on to the topic proper. Over to you, madam.
Thank you, Shirish, for having me here. And I would like to thank the Coimbatore Ophthalmic Society for giving me this opportunity to speak here. And it is special. It is special today for me because I'm talking about research in front of the postgraduates. Research has always been my first love, and it was first that I got into research and then into the leadership positions. It is important for me today also because I complete my 701st publications. So I crossed 700 today. And I was just noting that it happened to be today when I'm also going to address the postgraduates on the same topic.
Congratulations.
Thank you.
Congratulations, ma'am.
Thank you. Thank you. So I would be talking to you about research in ophthalmology, which may or may not interest many people. But I think it is a part of your thesis, and so you must know how to do it. The reasons why you would want to do research would be to learn about clinical or basic science question, and you are inquisitive. To foster future mentorship, because sometimes you want to do research under a mentor whom you idolize or who is a role model, to get some experience and also to strengthen your curriculum vitae, because if you're thinking of applying in the government jobs or in the institutes or in medical colleges, then you need to strengthen your CV because you have to face an interview. To get academic jobs in institutions, and even all practitioners, I mean, this is universal. Once they build up big practices, they flourish, and after that, they want to publish. So even if you have a big institute, the uh, the recognition that you get out of publication, out of research, you still want after making big institutes. So I think that is the be all and end all of everything. Then there can be two types. One is you want to investigate, and second is when you want to do for the healthcare delivery systems. And how do you commence research? So you will have mentors and collaborators. You have to find a research topic. You have to confirm suitability of a topic, define the question, plan the study design, calculate the sample size, and execute the research. So the potential projects, when because you are postgraduates, it could be anything. It could be just letter to editor. It could be just case report. It could be retrospective studies, which you may do of a retrospective data, which your guide or which your teacher tells you to analyze. Then there could be surveys. There could be questionnaire studies. Then, of course, as you graduate in research, you do prospective clinical studies and randomized control trials. And sometimes it can be even animal studies, provided you are interested. I think it is important to know how much in the topic that you are going to research has already been published. No point doing something which has already been researched. So you have to find out the gaps in the knowledge, and then you have to also see the mentor and the support systems where you're working, whether they are going to support you or not for research and consequently for publication. Very important to consult a biostatistician so that the power and the design of study are meaningful. And of course, nowadays, even for retrospective studies, you need to have ethics committee approval. So it is important to get that. Operationalizing the research question is important. So you formulate the preliminary research question, identify each of the main concepts. I think most important before you do research is review of literature so that you know what new thing you are going to find. Then the measurable indicators and what information should be collected to answer the question and how this information will be collected. Now, how do you write a manuscript once you've done a research? So once you do, I always like to write, when you do review of literature, then I always like to write the introduction, which would be a part of the review of literature, and add references. Then subsequently, methods would be already written in your protocol. Results is the first thing that you write after finishing the result, after finishing the study. And then following that is the discussion. Uh, Introduction, like I said, sets the foundation of the paper, should be brief, 300 to 500 words. Key elements should include what is known, highlight the gaps, comment on conflicting results, research question and hypothesis, rationale of the study, and don't over-reference it, but few recent references only. Then material and methods is also practically written as per your protocol. So what are the subjects, technical information, and statistical analysis? Then for subjects, you have to see how are they going to be recruited, whether they are animals or patients or volunteers or cases or controls, inclusion and exclusion criteria, the source of the population, the period of the study is very important. If it is about human subjects, then you have to obtain informed consent from everyone. And like I said, ethics committee approval has to be obtained. Then technical information is important. For instance, if you are mentioning some equipment, so you have to mention the manufacturer's name, city address in parentheses. Then procedure should be such that you identify it in sufficient detail to allow others to reproduce the experiment and results. References should be used for established methods, and the methods that are not published widely, brief description should be given. But if there is a method which is published widely and everybody is doing the standard way, you can just reference it. New or modified method should be described along with the justification, and all drugs and chemicals used should be identified, including the generic name, dose, manufacturer, and the route. This is just to show the way it goes. The keywords are written and then material and methods. And so this is the one which is highlighted, just shows how you would write a machine. So it will be the ALTK machine, Moria, that is the company name, and then where this company is located, that also has to be given. Then statistics again has to be given in detail, and that is best done by a statistician, and specification of any computer software that has been used in it. Then results should be to provide data relevant to research. They should be clear and simple. Whenever you write absolute numbers like 90 by 100, there should be a percentage attached to it. Then p-value should be reported. Graphs, tables, and figures are preferable. And whatever is there in the graphs and the tables, don't put it into the text then, because you can just refer to the graphs, tables, or the figures without having to repeat the same thing in the text. Then figures and tables are in accordance with the journal guidelines, which will vary. A citation should be provided in the text. Brief title for description will be required for figures and tables, and they should be standalone. Without having to look into the text, the figure or the table should be able to tell you just by looking at the legend, what does it say. Then figure format is there. Of course, now they are not very stringent because everything is online, but whatever the format of the figure requirement is there, that should be given. Then photographs, if you are giving for the subjects, they should not be identifiable. And like I said, do not duplicate data of figures and tables in the text. So this is how the tables and the figures would be. The legends are standalone. So without even looking inside, you know what this is saying. Then there are footnotes also present. Everything that you write here, CS, AS, AT, has to be, the abbreviation has to be clarified. Then in discussion, you have to summarize the original research work, emphasize novel and important aspects of the study, avoid repetition of material and data in the section, start with the major finding of the research project, and provide answer to the question or hypothesis, and do not overinterpret the data. Then in the discussion, you have to compare and contrast the results with the current literature, explain conflicts if any, always put a small paragraph about limitations of the study, clinical implications of the work, and for peers, you have to also describe problems which were undertaken in doing the study. Then there'll be list the unanswered questions and the possible research avenues that might resolve these issues in future. So it helps the future investigators to do research in that particular subject. Now, as far as conclusions are concerned, they should be brief. They should not state any conclusion which is not supported by results. You should link it with the goals of the study. The references are usually not used in the conclusion, and acknowledgements have to be brief, specifying the contribution. And also in this, you have to say whether it is industry-led or funded project, and papers which are presented at the conference should also be stated. Now I'm talking about thesis because that is something which you all publish. So again, with your guide, you should know what is the clinical relevance of the topic. Devote time to your thesis, because you may do less clinical work, but if you don't do your thesis, you do not get entry or passport to the exam. So that is something you can't get away with, and you need to do it. You have to analyze documentation from time to time and stay on alert for innovation that can be attempted. Sometimes while doing your thesis, you realize that part of it is already done and published. So you should be aware of what is already going on. And you have to communicate with your mentor or guide. And regular meetings with your guide are important to check progress of thesis and identify obstacles. And write the thesis and get it published at the earliest. Don't just do it as a mandatory process. Don't wait till the end. You can publish earlier than the time stipulated for your thesis. And of course, once the thesis is published, then this is a moment of relief. And I highlight this thesis because this was by my student and it got accepted just in one go when we tried to do publication, which means that if a thesis is done well, then it can get immediately published without even minor revisions, which were asked for in American Journal of Ophthalmology journal. Now, like I said, today is special for me because of this, and you can aim to do these publications. These have happened right from my postgraduate days until today, and that is something which I have never left ever. Whatever I may have whatever activities I may have done otherwise, because like I said, whenever you see your name in a publication, it gives you a different kind of joy and it gives you a different kind of happiness. And when you actually come out with solutions to the questions, then it is a different feeling. So when FACO came into being, we published a lot on the FACO emulsification, and each of this, whatever at that time we saw, we published, and each of this was an article. Then when LASIK came into being, again, we published everything. And so you can see the years are as when these techniques came into being. And then, like I said, even power of an idea is very small, is very strong. So like trypan blue staining of the anterior capsule, which all of us do, was published just as a letter to editor, and SLET was just published as case report, which again has become the way we treat chemical injuries. So if something is new, even if you write one paragraph on it, then it can, be landmark in the sense that people would keep referring to it again and again, provided it is innovative. A power of a case report. This was just a case report, so we didn't have we didn't have too many corneas. So in India, we normally use one cornea for multiple recipients. But we realized in 2011, we've been doing for years together, but in 2011, we realized that it is not published. And so once we sent it for publication, it was immediately published in Archives of Ophthalmology. Then sometimes you just have a case report and the reviewer tells you, okay, this is a case report. So you make case report and review of literature out of it. So that gets accepted faster. And this was the article which was done by my junior colleague, Dr. Praful Maharana, for his first publication, who came up with this case report, collagen cross-linking after keratoconus, because that was the first reported at that time, which was not very common. And then we wrote review of literature. So like I said, sometimes the reviewer himself will tell you that you write review also in this, and that's not difficult to do because you're already doing the case report and have reviewed the literature. And sometimes you may describe novel techniques like this, which people have not described before, and you come up with a solution. So again, that gets published. Then, like I said, you have to be very vigilant. At times, what happens is you present somewhere something and you don't publish. And this is one example which we presented. We got awards throughout the year, but we did not publish it. And we realized that somebody else had published it before us. So finally, we had to struggle to get this publication done. You do feel bad when you actually innovate a technique and somebody else takes the credit for it. Then problems as you go. So in cases of ocular Stevens-Johnson syndrome, we were finding they were having too many infections. So we came up with the question that let us study the conjunctival microbial flora, and that became a publication. Then orokeratoprosthesis in Indian population, because Oro-K-Pro is manufactured by Orolab. So again, we did the study and we published. Then whatever new instruments came, we again published, like this intraop OCT microscope came. So we published a lot of articles on intraop OCT guided surgeries. And these are all the publications from there. Then femtosecond cataract laser came, and then we published out of all of these. Then because corneal ulcer is a problem in India, so we realized there are no randomized control trials comparing Moxie or Getty with combination therapy. So we published this. Then again, this was another study which was done as a randomized control trial. So as you graduate from to a more senior position, from letter to editor, case report, retrospective studies, you do randomized control trials because you want to come with a solution. Sometimes documentation only helps. So this was 31 people who fell into a ditch, had chemical injury, and all we did is document on how they behaved. And this got published in American Journal of Ophthalmology. Then, like I said, always publish after you present, because if you don't, then it becomes a problem. And this example, I've already told you that somebody else published before us. No publication should be in your computer. It should be on the internet. Just to give you one example, uh, this publication got rejected 17 times. But every time it would come, we would correct it and send it to a different journal. So finally it got published. So you should not, you have to be perseverant about this. Rejection does not mean that it's not their priority. Rejection means that you have to keep improving it and sending it again and again. Sometimes you have to look for specific categories, sometimes you have to look for specific journals, but it does see the light of the publication does see the light of the day. Sometimes you have to change continents. So if there is an article rejected from AGO, Archives, Cornea, which are all in USA, change to UK or change to Australia or change to Germany. So what happens, the reviewers, their changes, so your chances of publication, they increased. Then, of course, once you publish, then you come to patents as you discover new drugs. And these were our two patents, Netamatrix and Netasol. And then as you publish in a particular field, you write review articles for current opinions of ophthalmology or for journals like Survey of Ophthalmology. And this is yet another article in current opinions. And then in a particular, like I said, continuity in research is important. So this was in chemical burns or ocular burns. So we kept doing randomized control trials to see what actually works. And all of these were again published. And then, of course, in very rare diseases like Stevens-Johnson syndrome, randomized control trial published because we work in a super specialty hospital which has patients with systemic diseases as well, and then subsequent publications thereof, also of Stevens-Johnson syndrome. Then as you go on publishing, other people from other countries make you a part of it. So you become a part of collaboration. And again, you publish the collaborative research, multicentric results of the various techniques. So I would just like to say in conclusion that all ophthalmologists world over are intelligent. All ophthalmologists think alike. You don't have to be smarter than them, but you have to be faster than them in conception of an idea, in execution of an idea, and in publishing the idea. So, and no amount of clever writing can cover for a poorly designed research project. And writing an appropriate style and presenting a manuscript in a structured, easy to understand format is an art. Again, scientific writing is a skill that is learned by practice, and once you get into it, then it's a thing which is very easy to do and something that you would enjoy. So, thank you very much for your kind attention.
Very impressive, Namrata. I think you're a real role model for people who want to publish and make a name in this domain. But for the young ophthalmologists and postgraduates, they always have a problem of not finding the right topic. How do you get the topic to start their thesis work or their basic publication?
So I always believe that thesis is the responsibility of the guide. So one is that you have to get a good guide who can give you a good topic, at least a novel topic, and even the simplest of the things, you can have something novel in them. So for that, I think whatever topic your guide gives you, because the postgraduates will have to do the topic which the guide tells you, you have to heavily research it. I think that is something which you can do from the PubMed. And at that point only, because if you do a good protocol, then half your work is done. You just have to chase the protocol. So at that point only, I think you have to be an equal partner with the guide to tell him or to tell her. Of course, they have idea about what cases they will get in their hospital to to get novel things out of your publication, out of your thesis or out of your research. Because that and whatever thesis you do, you feel only accomplished after you at least that publication you should do of your thesis. And I don't think it is difficult if you equally partner, research well in it, and give ideas to your own guide, or be curious and inquisitive, because some of the answers to the questions you may not have, but your guide may have. But you should come to a point when he or she cannot answer, give correct, cannot give answers to the research question that you are asking. That means that is something which is novel and which should be further carried out.
Thank you so much. I think it's like an addiction, which is probably most difficult to do the first publication, and afterwards it catches on.
Yeah.
You are already 701 and still counting. Congratulations.
Yeah. Thank you.
Yeah, Shrish, we'll go for the pinch
Excellent
hitter.
presentation, madam. So very inspirational. How do you choose the journals? Like you mentioned, if it is not accepted in Australian journal, you put it in American journal. But to get these citations, like you have close to 15,000 citations and more than 1 lakh reads. So what is your you choose your this thing for a particular topic you choose a particular journal or something like that?
So once you do your topic and you know what you've done, I think everybody knows what level it is. Suppose it's a very good study, a randomized control trial, I would always target ophthalmology. If it comes back from there, then we go to American Journal of Ophthalmology. I mean, it is according to the impact factor. And then when it comes back from there only, and it is an important topic, because I work in cornea, I would then go immediately to cornea. It would also depend, sometimes you want to be quick in the publications because an idea is too strong to be incubated and just remain with you. And like I said, there would be others who would be thinking about it. Then I would rather go for first instance only, go for cornea, finish it off there only, so that what happens is at least it is there on the PubMed. At times there is something very powerful which is not getting accepted. I don't mind going to the journals where the processing fees is there, because uh, it's open access. So now the things have changed. Earlier we never used to publish in open access. People had to subscribe and get the articles. But now open access is becoming very powerful and also very attractive, because at least it will be read by people. So it doesn't matter. I mean, uh, I feel at this stage, one, that you should, when you're doing very good studies, you should aim for high impact journals. But there are some studies, once it comes on the PubMed, it is the same thing. I mean, people will look at it whenever they are, trying to refer to that particular topic. So I
You
become more liberal in my approach. That is what I'm saying.
No, you still pay the article processing charges. Like nowadays, even JCRS has become a paid journal, and American Journal of Cataract and Refractive Surgery. That case report is a paid journal, and AJO is paid. Even clinical ophthalmology is paid. So, but you get very good quality papers coming out of these journals. Uh, like uh, you get sponsorship for
No,
publishing in these?
we don't get sponsorship, but suppose something is, like a ICMR project. So we put in the publication charges into the project fund only. So if you
Okay.
are doing a particular project, then you put it into the project fund. I don't know about other places, but in AIMS, the students also get thesis grants. They get thesis grants so that they are able to at least do the thesis, not publish, but do the thesis. And of course, the teachers get learning resource allowance, and I know that many of them spend from their LRAs, learning resource allowance for publishing. But best is when you're doing a project and it's a formal project, you put the publication charges into the project funding itself.
Okay. Okay. Fine. Thanks a lot.
Thank you.
Panelists, Dr. Rakshit, Pranesh,
Thank you, sir. I think, ma'am, that
Rajesh.
was a very incisive, master class on how to do research. I think more of a fellowship level talk where, people who are doing their fellowship, who are interested in doing research projects, whether it's a clinical or a research fellowship, all those points are quite valid. Uh, Something to really take home. I think I have one viewpoint on research in general at the postgraduate level and the PG thesis itself, and it might be a little controversial. But I do feel that I sometimes question the utility of having a thesis for postgraduates, because the having a clinician scientist and having a scientist and being a clinician at the end of the day in clinical practice become very different things. And I feel, at least at the psyche level of a postgraduate, when you are doing your PG, I remember this as a postgraduate myself. Thesis is something always from on the back of your mind from the time that you have to think of something that you have to. I got a great guide, so I didn't really have to struggle with that. But I know a lot of people who are stressed out just trying to work on their thesis, not focusing on core clinical reading, going through the standard textbooks, going through their clinical learning, and at each point using a thesis as a shield. Because coming in from the Indian education system from MBBS, that you have something, your measured variables are in terms of exams and other things. And those tangibles are suddenly lost in post graduation when reading is on your own. You're on your own to gain knowledge in that subject, and then you end up using thesis and thesis work as an excuse not to really do the core reading which you should be doing. Sometimes I do feel whether the point of a thesis is to get a postgraduate inclined in research, and also to kind of interpret research and understand how research is to incorporate in clinical practice. And I wonder often if there are better ways to do this than burden someone who's doing a clinical course with saddling them with something research oriented, which very often is done suboptimally without quite understanding the principles of research, published or not. But this is just something I often think of when I see postgraduates, and I even think of myself in the past struggling with research.
So that's a good take, Rakshit. But I would just like to say, I think the role of the guide is very important in this, because when you have a student, the guide has to assess. Some of these students are exceptionally bright. So for those people, I will not hesitate to give very good topics. But when I know the capability, and I think that is for all guides, when you know that this particular student will be able to do only this much. I mean, thesis should not be a hurdle. Thesis is just a stepping stone so that the person can give the MD exams. So if I know that he's not going to, he or she will not be able to handle a very difficult topic, I immediately change the topic, because I don't want to make things difficult for the student. I want to make it easy, for him or her. And I think
Absolutely,
that,
ma'am.
yeah, that should be the thing. There have been times when, people have questioned, why have you changed such a good topic, like something on biosynthetic cornea? But that cannot be given as thesis, that's something for a fellow to do, or maybe for junior consultants to do. So you have to assess what topics, like I think Dr. Krishna Prasad also asked the same sub question, that what topic you are giving. You have to assess the aptitude and the capability of the student you are working with. So immediately make it, simpler. You know that he or she will not be able to handle it. So I think that evaluation the guide should do.
One
Rakshit,
point I just would like to add is, madam, not only in the perspective of postgraduate thesis, but also when it comes for their life, they PGs are stepping into a new career. They need to be taught how to work smart than working very hard. Sometimes when they start up with the thesis, they are not very focused on things what exactly they wanted to do. They are unfocused, and dilution of their hard work is the issue. And probably when we are mentoring them properly into a focused, smarter work, and with a proper decision of the topic which madam has clearly told, and more than that, how much is the time available for them for their follow-ups, and is it significant enough which will impact the outcomes. And if we, by looking into all these things, and if we are catching up with the thesis, probably yes, they should be able to do well, as well as know that how to work smart than being working very hard. That's one thing I think comes to my mind when you, Rakshit, brought about this point.
I think before we go to Dr. PVR, I think I just my take on Dr. Rakshit. I think Rakshit has really rattled the ship and won the hearts of all the young ophthalmologists. I understand, but I think we have to look at the perspective. I think you are only talking about what is happening on the ground, but the intent is important. See, when we learn ophthalmology as a post graduation or any specialty for that matter, so the research mindset is a part of the curriculum. See, thesis is mandatory because there's basically a research mindset, and you may wish to actually become like another Namrata Sharma. If you really wish to really find passion in that and you really get the right ecosystem, you can proceed. But I think taking it away completely away from the curriculum as a mandate probably is not right, because the presently the all the plight of the students that we have is because of the poor mentorship. That's the whole idea. There's nothing wrong with the student or the intent or the idea of a thesis research, because everybody should have. See, we have so many problems that we face. Every problem that we face in clinical medicine is a research question. We want to solve the problem for the community. So finding, once you get that, so you want to share your best practices, how you have solved the problem within your setup to the entire world. So that's something is which is probably very justified, but the way it is being put into practice may have its own flaws. That
Point
is the
well
whole
taken,
issue.
sir. Point very well taken, sir. My only point was essentially to bring out the fact that certain stresses that come into picking the thesis.
Yeah.
For example, even if you send this to national board, oh, we cannot do a retrospective study because this will get rejected. Oh, our study cannot have less than 50. Such trivial things that, the person who approves the thesis should not be looking at. Ideally, if it's looking at clinical questions, even a pilot study of 10-15 patients, which is of the student's brainchild, should be accepted. The problem is when you put all these other limitations, you end up diluting what the student actually takes out of it. That was my only point.
I completely agree. At the same time, also I have been listening to the free papers which have been based on their thesis in many conferences. I've been a DNB examiner. There's a thesis, they are supposed to tell about their thesis. Many students fail to actually even narrate their actual research question. If you really dig deep, they have no idea. It's a very shallow work, very superfluous work. So I do understand. I see a lot basically the non-participation of their mentors behind all this plight. I think going forward, we need to look at this. Probably we need a strong mentorship. Maybe AOS can chip in. Dr. Namrata is here. Dr. Prashant is here. So I think AOS can also chip in. Many private organizations and individuals can chip in to really solve this problem, the gap that we have between the mentoring and the thesis students. I think that should be the way forward. Thank you so much for Rakshit for bringing in.
No, one thing is definitely there that Rakshit, you can ask all the questions that you want to at the protocol level. Once the thesis is over, then you cannot ask questions because it's done. It has to pass. I mean, you can't say, why didn't you do this once the entire period is over and everything is over. And it is for the mentor or the guide to answer, not for the thesis candidate to answer, because it is not his doing or her doing. So, like I always say, all questions that you have to ask, please ask when the protocol is being presented, not when the thesis is being presented, because it's over. The game is over at that time.
Yeah, thank you so much.
Thank you.
Trish, for the finisher of the match.
Thank you so much. We'll move on to the last topic of the day. Thank you, Prasanna, for waiting till the end. So, Dr. Prasanna is going to talk on how to produce a high quality surgical video.
Thank you, sir. Hope my screen is
Yes.
visible and I'm audible. So first things first, thank you, Sri sir, President CSOS, as well as the Secretary of CSOS, for this wonderful opportunity, and to the whole team. Sir, actually, this is a very candid talk, and I've kept it. It's kind of sounds odd, but it's an 18-year journey, and I'm into video editing since 2008. And my colleague and classmate, Dr. Pranesh, is here. So these are some of the fascinating things which fascinate people like us when we were even in mid school. And movies like Blade Runner 2049, and this was one of our pictures in 2008 when we made without any advanced tools. You can see only the shirt is looking green in color. So we are all millennials, at least myself and my peers. And then when you come into Gen Z, so this was one of the movies that we took, and this is a journey that is almost close to 2 decades in colleges where we used to, do things for the love of things. And there were short films that myself, and also we had one with Dr. Pranesh as well. He was my batchmate. And so these are some of the after effects we did even 18 years back when there was no AI and all those stuff. And this was our film poster. So coming to surgical video editing in ophthalmology, where I was able to mix that into this. So these are some of the disclosures, or maybe the things that I use or I prefer bias to. Vegas Pro, Movavi, Adobe, DaVinci, and Final Cut Pro. And the editing techniques I use is split, trim, fast forward, slow motion, text overlay. I use metaphors to compare screenplays to a surgical scenario. And I also sometimes use the thing that Christopher Nolan does, simultaneously use a timed screenplay where two incidences happen simultaneously, animations and anatomy marking. So these are some of my editing techniques and these are some of my softwares. And I make sure I cater it to that particular condition that I want to convey to the audience, or rather, award is just a byproduct of the video that we are going to make. So again, going back to my short film that I made in 2008, these are some of the layers. You can see we use 7 to 8 layers back in the day when I was just learning along with some of my medical colleagues as well who are passionate. So this is a journey from editing. Like currently, I am part of the TNOA journal as well, and I'm very fond of what I do. And finally, when an editing person or a person who's more interested into video making, film making, if he becomes a surgeon, what happens? I think this is one of my fond memories with Dr. Aik for one of my MIGS videos, which won in IRSI. And I'll just take you through simple video cuts and video editing. So this is one of my YAG own videos where you can see I'm in the frame itself. I put on left hand side the smartphone with an elephant boat adapter that, and on the right hand side you can see me using an anime to show that I'm recording this video on a smartphone camera on the YAG mission itself, and I'm just moving it left and right. And once the photo disruption happens, you can see that we want to document photo disruption. Then the bubble starts coming. You can see the bubbles have started coming. I'm just pausing the video here, and then the bubble starts moving towards the 12 o'clock position, and then you can see the gush of aqueous. So ophthalmology field being an imaging field, and now what am I doing is, this is one thing I learned from the movie Tenet. You can actually go back. I'm actually backwarding the video. See, I'm just, you can see that after I have done the video, I'm just making sure it goes back, because people understand if you just rewind it back, what was the finding that you had to pick, just rewinding it a bit back, see the bubbles are going, the PA is not there, then again I'm forwarding it. So in Tenet, I got this idea from Christopher Nolan again, and then again you can see this is the first documented photo disruption video where you can see the photo disruption. So you get ideas in day-to-day scenarios, and I use a simple zoom in effect. And once I zoom in, when I come zoom out, I come through the same hole. This gives you a lot of dimensions. So now moving to a second video, this was one of the videos which recently won an award, which I wanted to show. The set of videos I'm showing, which was all done together. So I'm using a titratable suture or a releasable suture. So you can see what am I trying to do, and I'm just trying to take the sutures, and a beginner may not know where I am taking the suture. So let's dissect this video going back, right? Right. So this is a trap flap has been taken, cornea 1 and entry exit through cornea 2. So that is how you take the suture, first suture. Then comes the base of the cornea, rather the base of the flap, cornea 3. Then you take the sclera 1. So this is how we teach, right? So 1 cornea, 2 cornea, then the third is also cornea where you take it in, come out through the sclera. Then finally you take near the apex, that is sclera 2, and then you come out outside the apex, that is sclera 3. Now see what are the effects I'm using after you have taken the suture. I'm through doing 4 knots, and I'm zooming in and showing 1, 2, 3, 4, the 4 knots. I'm just going back a bit. So just see 1, 2, and 3, 4, the 4 knots that I've put, the loop. Then finally, where am I catching? Again, you need to show zooming in, zooming out. So this is a cinematography that DC uses in all their films. So you can see I'm zooming in, and you can see I'm catching it in the loop where near the flap area. And now I'm tightening it. So that's all it is. So releasable suture is done. So everybody talks about releasable suture, but how can you show it in a very educative way? And then you remove it in the post-op, right? You don't end it there. When you remove it in the post-op, how does the bleb forms? Again, I'm rewinding it. Again, I'm showing it. So this thing of edit gives the viewers a very visual kind. I'm just going back again. So you can see the releasable suture is put, and the same suture in slit lamp, when you remove it and you're giving the massage, the bleb forms. Somebody misses it out, I show them, I'm just rewinding it back, and again the massage comes. So now moving into the next case. So even the simple transitions, right? You saw how I transition from this case to the other. I'm going through the pupil of this patient and coming out. Another case 3. Patient comes with serous choroidal detachment, over-filtering bleb with serals negative. I keep it very mathematical when it comes into surgical video editing, and then take them into a real-world scenario. As I showed, a bleb is there, and I'm trying to make sure I form a barrier around the bleb. So this is the compression suture. So as and when I'm putting the compression suture, the animation on the right-hand side, you can see that the X-shaped suture is now coming on the animation also. So somebody who needs an animation to understand, they get the animation to understand. Somebody who wants a real world surgical video, they get the real world surgical video. So the X-shaped pattern is put on all the sides. This is the over-filtering bleb where you put the compression suture. So this concept of compression suture, we are giving it in 3 frames. We show the history where on the right hand side you are seeing the serous choroidal detachment, over-filtering bleb. Sedal is negative. Why sedal is negative? Because the bleb is not leaking. It's just that the bleb is over-filtering. So there is nothing wrong with the conjunctiva, but there is something below the conjunctiva that is causing an bleb to have an over-filtering bleb. So the history is there, the animation is there, and the real world surgical video is there. And now if you cut this frame, I'm showing the compression suture in the parallel shaped one as well, the Palmberg compression sutures, which is called where you put it in a parallel shape, not like an X shape. So bringing in one concept after the other is very easy. So moving into the next one, where we do a transscleral CPC, a cyclophotocoagulation. What we are taught is, okay, we get only the outside view, the scleral view, right? So that is what we are seeing on the animation on top. But the real thing is what happens in the Miyake apple view, inside view, what happens within the eye. If we are inside the eye, what is the view that we'll get? So you can see here on the screen, as the energy levels are delivered from the sclera, you can see how the pupil is actually being drawn. The pupil is being drawn, the ciliary body bursts, the ciliary body bursts like a volcano. Again, going back a bit here. So this is what a Miyake apple view can give you. And these are real videos which you can do it in a goat's eye. It's not that difficult to document it, an inside out view. So adding these flavors of touch to your transscleral videos will give you a lot of layering to the concepts. You make them teach as well as you deliver more novel concepts which are already there. The surgery is well known, but how can you give it differently? Again, with the same ECP probe, first you are seeing that I'm just showing it on top of the iris. When you show it, see how you give the effects. See how the effects come. I'm just playing this video here. Once you show, the angle should come. Swalby's line, non-pigmented, pigmented, scleral spur, root of iris. Now you are going below the iris and you are showing the ciliary body. And how you are hitting the laser and treating the ECP. And then again, you can go back to the angle and show before ECP, after ECP, whether the ciliary body is constricted, and that pulls off sometimes in angle closure cases and opens up the angle. So bringing more concepts into video making is very, very possible. And again, this is one of my favorite videos for malignant glaucoma, iridozonulo, hyaloidovitrectomy. These are one of my 2 cases that I wanted to show. So first we do a PI, we make an opening in the PI. Then I'm just zooming in a bit and showing the PI. Then I'm putting the trocar. And once I put the trocar, I'm again going back, I'm replaying that video. So again, when I'm taking the trocar, see the gush of aqueous, which has misdirected into the vitreous. I'm just going back here. Again, I'm playing this video here. See, once I remove the trocar, see the gush of aqueous, the chamber deepens there itself. Then you do a posterior vitrectomy or an hyaloidectomy. And then through an hyaloidectomy port, you are coming into the, you are breaking the zonules and then seeing whether both the instruments are touching, the anterior segment instruments and the posterior segment instruments. Again, in this case, when I'm coming through the posterior root and breaking the zonules, it also does an extensive PA as well. The PA has already been done, but when it comes up, you can see that it catches the iris, and this is a clear sign that you have made a continuum between the iris, zonules, and the vitreous, and the chamber will easily deepen on table itself for malignant glaucoma. And you can have more and more videos with animative learning, avoid perforators. Satyan sir used to always tell that, and in the early stages, I used to make that mistake. So again, you can see I'm using a boomerang effect to go back and forth and show how I did not avoid the perforators. And it just keeps bleeding, right? The 2 black spots which you see, you can just avoid. And again, this is one of my case. I'm a twin side trabeculectomy surgeon. When I finished off my trab, I felt that the flap was very difficult to take. And when I came to my cataract, other side temporal, you can see the eye is nystagmus. It's moving. The base is shaking, right? Again, when I came back superiorly. So these are some of the cases rarely you will find, And this is again a 5-0 prolin suture in the RD lumen during those times before Supramid. We were working on these 5-0 prolin and long surgeries like tubes for 25 minutes. See how crisply you can edit. I'm just editing it for 20 seconds. You can 20 seconds edit these kind of sutures. Your mistakes like a fish mouthing in a trabeculectomy case where you can see the flap was not triangular but a quadrilateral and there was a fish mouthing here. So to correct that fish mouthing, what you need to do, I'm just going back here. See the fish mouthing. If you put an apex flap, the fish mouthing will happen because the physical vectoral forces will not be adequate to close the flap. So you need to put a flap perpendicular to all the straight lines. So you have to put a suture like this. So that's how you do it. You can teach, you can actually edit, and this is a PA again. When I did the PA, you can see it's continuously bleeding. Basic beginners, what the mistake you do, you again put saline. Never do it. Again, just keep the flap itself and that should take care. So these are some of the videos which we keep seeing day in and day out, but the same day you have to go back to your drawing board and edit. I spend at least 2 hours a day for this. I'm very particular about video editing when it comes. This is one of my congenital glaucoma babies. The right eye, all parameters are normal. So see the screenplay. When I move to the left eye parameters come. When I move to the right eye parameters come. It's purely one of the cinematic edits that you have. And then when you go to do your surgery, just keep the steps very crisp. What is that you want to do? So this is again a partial thickness scleral flap, a trabeculectomy followed by a trabeculotomy, where the flap is hinged at the limbus and the Schlem's canal identification is done. And then you put the trabeculotome and do the trabeculotomy. Put the trabeculotomy, open it up on both sides, then do a trabeculectomy. You can see a trabeculectomy is done, an ostium is taken, and then you close. And then it doesn't end there. The child comes 2 months follow-up, 3 months follow-up. What am I doing here? I'm patching the seeing eye and the non and rather I'm patching the non-surgical eye. And the surgical eye is not patched. So how the child is reacting to us, how the child is playing to us. So this is one of a visual rehabilitation video that we submitted in the World Glaucoma Congress, which was well received. And how the child, every time when the child comes, the eye which we operated, we don't patch it. We patch the other eye, the normal eye, and see how the parameters are resolving. And there is a story that you tell at 6 months, 1 year, how the child starts to get its visual rehabilitation back, and how you start connecting with the child. And at 9 months follow-up, the child starts to get more happier. And then at 18 months follow-up, the Boyac candy test, how the child picks up the first Boyac candy through the operated eye, the left eye. You can see it's a Sturge-Weber port vein stain in the left side of the face. And the child is now picking a simple Boyac candy, first attempt, second attempt. And how you give the extra layer for the video is that edit, see the first attempt, second attempt, follow the literature and give it more presentable. And the child touches it, the first attempt, second attempt, you are freezing it, showing it. And then how you are aligning it is when the child touches it, see, I'm going into another anime. The child, when it touches it, it goes into a spiritual level. So these are some of the videos which really touches the heart of people. And even this was one of my very, very fond cases where every time when the child comes, I have a great time with the child. So animation guide, again, it's very, very important and very powerful. See, for example, again, in this particular surgical video of a mixed case, I have the foot pedal anime done. So when I'm putting the gonioscopy, what am I doing? My left hand is putting the gonioscopy. My foot pedal is now going to zoom in. You can see that I'm zooming in. So I'm just showing that I'm zooming in. And now I'm fine focusing. I'm showing that we are fine focusing the angle. So now we are fine focusing the angle. Once I have fine focused, I'm zooming out. So it's an unedited video again. So you zoom out. Why am I zooming out? I need to identify the main incision to take the instrument inside. So you take the instrument inside and then start doing the procedure. So it's a KDB procedure. So that's it. You just do the procedure. uh, it's just a 180-degree excision inside out and you complete the procedure. So lot of things. Again, if there is a bleeding inside the eye when you are doing the procedure, how the bleeding has to be treated. A simple, again, animation video here. In gonioscopy, the refraction behaves differently, direct gonioscopy. It comes in a C-shaped pattern. The blood comes out in a C-shaped pattern. You have to put that extra Elon GB Pro for the blood to come. So you connect concepts, you give a screenplay as well as you have a story to tell. So this engages people. Collage cutting for ending your presentation, of all your eye stent implants. it gives like a good snap-like feeling where just like that, when you 2, 3, 4, 5, all your implants you can just show when you're ending your video. And I also publish all my videos, as Namrata ma'am was telling, all are published in PubMed Index journals. Most of them are teaching videos, OCT, surgical videos, and whatnot. So thinking in figures is what I would like to say as a last point before I close. Like a pupillary block. It's a 10-second animation again made by myself. A pupillary block happens here, acute angle closure attack happens here. This concept many people don't understand on day one. Sometimes many people don't understand it even 1 month into the presidentship. So simple concepts like this. Why do we do a ARC-PA? Because the cause is here and the effect is here. Again, before and after cataract surgery, what does it happen? So these are all the theory. Relieves pupillary block, iris posterior moves. So we can show everything in videos. Iris falls posteriorly, ciliary body falls posteriorly when you do a simple cataract surgery. Even the scleral spur falls posteriorly. That is why the angle trabecular meshwork pores expect to be opened up. If there is a PAS, that breaks up, and sometimes that also happens. And very important part is dub your own videos. Make sure you give your own voice for your videos. And the future is AR and VR. I think uh, the current Gen Z kids, again, my daughter being another Zen Alpha. So these guys are all into this, and all these concepts are published in my channel. We have around 4.5 subscribers for the 97 videos. And last year, I was very lucky to win the grand prize in the World Glaucoma Congress. And this being a CSOS webinar is very close to me. I've been 10 years in Coimbatore for my undergraduation as well as my fellowship. I was able to acknowledge my mentor, Dr. Satyan sir, on the podium, and he was also there. And we were able to get this prize together, which was the biggest prize in the film festival for the World Glaucoma Congress last year for one of my videos of this. And not only that, as power of mentorship, again, all my teachers, Sundar sir, my UG teacher, and LA to LA, Trichy to LA. This is one of my another favorite videos, which was able to make a merit. This is there on YouTube. For want of time, I'm not playing this video. This video was a pitch of my startup that I have created in 2021 called the Mahatma Center of Moving Images Private Limited. And we were very lucky to work with Shrish Kumar sir also for many of his projects. And the startup of ours for one of our innovations, which we actually brought down into the market, was one of the winners for ASCRS Sightline competition, where our team was able to bag 5,000 US dollar grant for our startup. So I think it's a very beautiful time. And I just went back and bought a laptop for the 5,000 US dollar. It's a MSI Vector A18HX A9W model. And I just invested it back. And I think it's a very nice time, my dear friends. You can do a lot of things. Recently, when I did the hydrous implant, I was the third surgeon to do the implant. I keep editing then and there. Every day you edit your videos, 2 hours, it takes a day. You have to sacrifice some amount of that particular time in the day to edit your videos and get it out in the market, and be it YouTube or whatever. And recently, I've started editing my fellows' videos as well. So we are working on one of the videos where I'm making a video for my fellows who come to me for mixed training. And this is one of that data set of Dr. Shivani from Indore who came for mixed training. So we edit their own videos and we give them back their own videos. And this is one of the videos where we may also participate in competition soon. We have a lot of good collections in this. And these are some of my trainees who gave me a lot of good collection videos in the last 1 year, where we were able to train 13 people. So thank you once again. If you guys want to reach out, if you guys are seeing me on YouTube, please do reach out to this WhatsApp channel, Instagram ID, or my mail ID. And thanks to Shri sir. Sir has been a great motivator for me when I was taking a very lateral path. Sir, from 2022 onwards, or even when I was in Coimbatore with Satyan sir, my mentor, sir used to always say, think laterally. If you have an idea, make it into a full-fledged fruit. And he's been one of my strong motivators, along with again, another PVR is also here, another senior friend, as well as Prabhu sir. Thank you. Thank you to both of you and the whole team CSOS. Thank you.
Prasanna, I have a question for you.
Yes, sir.
So whatever the videos you have presented is like high quality and kind of competitive and prize winning videos. What I wanted to know is like, can you suggest some simple software for a postgraduate point of view which is going to be really cost effective, or probably a free version or something where they can edit their own surgical videos or clinical
Yes, sir.
videos, mainly for the presentation purpose, for the PowerPoint presentation, things like that.
Yes, sir.
Something which is very cost effective for the postgraduate point of view.
Definitely, sir. Sir, I think Pranesh can also add on to that. But what
Yeah.
I what really inspired, things which inspired me was GoPro. In 2019, I learned it from Venkatesh sir. The video that we used for gym, I think that was around 25,000 or so. And even, sir, recently, before live surgeries were banned, well, in Vellore Eye Hospital, we did a live surgery. That was one of the last that we did in TNOA, where we used a simple adapter for a smartphone, and we took connected that in the side scope. And I think these are some of the very frugal ones. If you have a side scope viewing system, there are many adapters, like John Davis sir has also created some adapters for that, I believe. And these are simple adapters where you can just connect your smartphone and you will get great videos, sir. I think, sir, even some of my iPhone videos are much better than what I would say in real Sony camera or other videos that I use, because the photo description that I showed, sir, I captured it in an iPhone 16 Pro with the slow motion setting in that and the 700 rupee elephant boat adapter. So I have experience in with these adapters, GoPro, and these things. I think Pranesh also, if, I think he's also more into this. You can add if I have missed anything.
And that is for capturing the videos. Is there anything to edit videos? Is it
Sir,
software which can
sir,
help in editing
sir,
videos?
sir, editing. If any beginner, sir, they can start with iMovie, sir. iMovie is what I started my journey with. QuickTime Player and iMovie in my own Mac system. It's very good, sir. Like, as the settings I told, splitting the video, slow motion, fast motion. So sometimes we think too much of graphics is needed. No, sir. Actually, the own content with from Christopher Nolan's movies, what I realized, and even with Zack Snyder's movies, Man of Steel, he uses a zoom in and a zoom out. I feel this is very, very less utilized by people. People put a screen and they keep playing and the attention loses. But if you really want somebody to focus where you want to focus, either the same video, you can pause it, zoom in there, put an arrow, show what you want to see, then remove the arrow, remove the annotation, zoom out, again play the video. It takes an extra time to make it, sir, but the results will be very nice and very rewarding in terms of conveying what we want to convey, sir.
And do you have anything like me, who a person of Android?
Sir,
Not iPhone, man.
sir,
Well, there's
Pranesh,
so many softwares are available for basically simply cutting and pasting. So many softwares, Filmora, you have KineMaster, so many. You have CapCut. It's not available in India though, but so many softwares are there, sir. I think the options are endless. Uh, but for to just but to have additive to apply masks to have to apply something to make some edits to overlay or something, that you need expertise and you need to learn about it. But for basic cut and paste, I think like it's very easy to learn, sir. It's the
I would
easiest thing to
suggest,
learn.
Rajesh, Movavi is probably the most user-friendly what I've seen. Of all the
Okay,
things,
sir.
Movavi is the basic. You can start with Movavi, you'll be very happy. I think most of the things that he told, it's basically not the software, it is the person how to use the
It's
software.
learning, exactly. Yeah.
Basically, everything has a bit of everything.
Mm.
May not be in the, at least in the basic form. How you use those functions
Hmm.
and how you use the creativity. It is like a movie direction.
Exactly.
Camera is same, but how you use the camera, how you edit the movie, basically, it's all about like movie editing is about creativity. It's the right brain. I think PVR Prasanna has some extra space on the right side of the skull. I think some
Sir,
new lobes have
actually,
been added. So that's the thing. Probably it is the lobe, right-sided hemisphere that matters more than the actually the software.
no, trained by nice
Excellent,
sir,
excellent.
and lucky to be, as I told sir, Sri sir has been a
Thank-
major influence.
Thanks a lot, Prasanna. I think whatever the videos you have shown are all like award-winning videos.
Yes, sir.
And you made two animations for me, and both of them got first prize in TNY and in All India Ophthalmological
Thank you, sir.
Society meeting.
Thank you.
So thank you very much. And
Pleasure, sir.
I think we can end this session. My sincere thanks to Sun Vision from Sun Pharma for their participation in this webinar. And thanks to Numerotech, Sai and Mrs. Manjula for their technical support. Thank you, speakers, moderators. Dr. Krishna Prasad, you held the fort entirely throughout the program, single-handedly you handled, and my sincere thanks to all the expert panel, and we are honored to have luminaries in the field of ophthalmic education, having spent their precious time with us this evening and sharing their thoughts and knowledge. And PGs, I think as you move and sharing your thoughts, uh, training, remember that you are not just treating eyes, you're transforming lives. We encourage you to take these insights into your practice. Let us not stop at learning, but start implementing. I wish you all success in your academic and professional endeavors. Thank you very much. Thank you, everyone.
Thank you,
Thank you.
So,
CSOS. Thank you
Thank you,
so
Thank you
sir.
much.
so
thanks
much.
a lot,
Thank you.
KP. Thank you. Prabhu, you want to tell something?
Yes, sir. Thank you, everyone.
Thank
I
you.
think a lot of
Thanks a lot. It
we
was a
covered
very nice
almost all
session.
the things of evolving from a postgraduate to a practitioner. I think we have covered all the areas like exams and ARC, research and publication, video presentations, and how to become a practitioner, how to evolve as into an entrepreneur. And I think it made a great sense. Thank you, Krishna Prasad sir, and thank you all the panelists and speakers. Thank you, sir.
Thank you. Thank you.
Thank
Thank
you.
you very
Thank you.
much.